Hello, thank you for joining us today. My name is Cecile Rooker. I'm the President and Executive Director for the International Foundation for Gastrointestinal Disorders, or IFFGD. Today's programming is about advocacy and learning how to advocate for yourself, not only in Washington, but also in things that we have to deal with quite often, which is the insurance process. Throughout today's programming, we're going to give you information and insights about different current legislative agendas that are part of our Washington congressional sessions right now, issues that you can take action on immediately, legislation, bills, funding for research for chronic illness, and many other things. We will also talk to you about how to talk about these things with your legislators, how to be a good advocate for yourself and others in the digestive disease community. Thank you for joining us. We hope that you are able to learn from today's programming and be able to be better advocates on the Hill. If you have any questions at all throughout the day and want to contact us, please do. Our email address is iffgd@iffgd.org. Thank you so much for joining us today. Again, I'm Cecile, and we just welcome you.
Hello, everybody. I'm Erin McKeown. I am the Associate Director for Federal Government Affairs with the Crohn's and Colitis Foundation, which is a fancy way of saying I'm their lobbyist. I am their one-person Washington, D.C. office. Everywhere I go, I am the D.C. office. I have been with the Crohn's and Colitis for about a year and a half, and I'm also an ulcerative colitis patient. So I know this issue from all angles. What I'm going to talk to you about today is what's going on in the realm of copay assistance and what we and many other organizations are doing to try to protect copay assistance. I'm going to start with what copay assistance is and why it's needed. If I'm talking to patients or doctors, you probably know this already, but this is how I explain it to people on the Hill. The cost of medication for digestive diseases is astronomical. If you look at the cost of Humira, if you're paying list price per month right now is about $6,700 per month, which just makes these medications inaccessible for the vast majority of patients. And because this is happening, pharmaceutical programs have put into place copay assistance programs where they'll help patients meet the cost-sharing requirements of their insurance. Here I'm talking about deductibles or co-insurance, which are, in many plans, considerable. If you listen to TV and you see an ad for, let's say, Risalto is one I saw yesterday. If you can't afford the price of your medication, get in contact with whomever and we'll help you meet that. That's what this is. Sometimes they're coupon cards or credit cards that help patients pay for their medications. What we do know about these programs is that the vast majority of patients who receive copay assistance earn less than $40,000 a year. And these are people who, if this assistance did not exist, would not be able to take the medication that we know will help them. We know that once cost-sharing requirements reach about $250 per month, there's a significant drop-off in the number of patients who will fill those prescriptions and take them. That leads to patient abandonment, which is really horrible when you're talking digestive diseases. If you get somebody into remission and they're stable, the very last thing you want to do is mess with their medications. You could throw them off and the disease could progress. We know that more than half of the IBD patients, Crohn's and colitis patients, that we recently asked said that they are using copay assistance right now, and the vast majority of patients could not afford their medications without them. What is happening out in the market right now is insidious. Insurance companies have realized that there's this money floating around, that copay assistance is being offered by foundations and by pharmaceutical manufacturers, and they're trying to figure out how to make this work to their best ends. What they have been implementing increasingly, particularly 2022 forward, are these programs called copay accumulators. They work like this. You're the patient, you have this high-cost drug, you can't afford it, you get copay assistance. So you use that coupon, you go get your drug first few months of the year until that copay assistance runs out. Normally, it's not enough to cover the entire year because the thought is once you meet your deductible, then your insurance program is going to pick up those costs. When you get to the point where your assistance runs out, the insurance company comes back to you and says, no, none of that counted. That didn't come out of your own pocket, your own bank account, therefore we're not counting it towards your deductible or your out-of-pocket requirements. And when they do this, insurance companies are basically double dipping. They're accepting the cost-sharing requirement from the insurance company and then turning around and getting it again from the patient. And it's nasty. What we know is when patients get this copay surprise and realize they haven't met their deductible, many of them abandon treatment. Now, this has to do, I'll talk about this in the next slide, or the one after this actually. This is just a visual representation of how it would work for a theoretical patient who has copay assistance of $4,000 a month and a deductible of $7,000 under a copay. Without a copay accumulator, their total out-of-pocket spending would be $3,000 because they have to meet the difference between the assistance program and their deductible. Under an accumulator, they have to pay the entire $7,000 out of pocket because the amount that is paid by the copay assistance plan is not counted. So it's costing patients a significant amount of money. The way these came about in 2021, in a last-minute surprise, the prior administration changed the definition of cost sharing, a legal definition under the Affordable Care Act. And it specifically allowed insurance companies to institute copay accumulators for medications other than small molecule drugs that have a medically appropriate competitor on the market. Prior to 2021, those were the only drugs that could be subjected to copay accumulators. So there you're essentially talking about a patient choosing to take a brand name over a generic, even though that generic was medically appropriate and could do the same job. In that case, they were allowed to use accumulators. This law changed it so it was open to all plans. HHS at the time said that they thought this would have very little impact, that not many insurance companies would actually put these into place because who would do that? So it's no big deal, don't worry about it. Yeah, they were wrong. Right now we know 83% of the insurance programs out there on the commercial market right now actually are using accumulators. Once we all figured out what was going on with this accumulator thing, and once we figured out how to actually explain what they are, patient groups banded together and sued the Department of Health and Human Services in 2022, saying that this change violated federal law. This wound its way through the court system, and on September 26th of last year, 2023, these patients actually won. And district court here in Washington, D.C. decided that it was true that HHS had violated federal law in the way that they changed the definitions and implemented copay accumulators. But where we are right now, so this means legally, as of September 29th last year, accumulators are illegal. They're contrary to federal regulations, unless you are taking that medication that's a brand name with a medically appropriate generic competitor. At first, HHS thought that they would appeal this decision to a higher court, to an appellate court. We worked hard to tell them we really thought that was a bad idea. And this January, HHS actually dropped their appeal, said, all right, we're not going to appeal this. We realize that this is true. What we said in 2021 is now the law of the land, but we're not going to enforce that. We know we should. We know that they're illegal, but we're going to do nothing about it. We know that insurance programs are using these, but we choose not to enforce the ban. So this puts us as advocates in a strange position. What are we going to do about this? Well, we know the lay of the land is that HHS has said they were going to come out with new rulemaking. This rulemaking will supersede all of the other stuff. We'll make a brand new law of the land, and we'll say who can and cannot use accumulators. This regulation is now winding its way through the federal government. We don't know when it's going to come out. We don't know what they're going to say. One would hope that rational minds would prevail and they would agree to the original definition of cost sharing. But we don't know because they're not enforcing the current ban. We also know that the same groups that banded together and now larger coalition are also contemplating further legal action. We're looking for patients who are right now subjected to copay accumulators and suffer harm from that, so that we can say that we can bring a class action lawsuit against HHS asking them to enforce the regulation that they should be enforcing anyways right now. But legal action takes one heck of a long time. What are you going to do right now? We're in the sad situation where patients have to advocate for themselves. We won the court case. We're trying to work on this in Congress. We're thinking maybe further lawsuit, but right now, probably around this time of year is when people could start running out of copay assistance and get to that copay surprise and are going to be harmed. First of all, we want to know if that happens to you. Because we want to gather this information so we can make the case that this is a bad situation. One way is through legal action, through a class action lawsuit. And another thing I want to do, I think would be super fun, is just a really great social media shaming campaign. Going after the insurance companies. Hey, United, you know this is illegal. You know you're harming patients, but you're doing it anyways. We know they listen to that.
Well, why don't you?
We need the stories. We need to start collecting the stories right now so we can do that. I have a couple, but these are people who are actually able to get themselves out of accumulators. So I don't have one right now of a patient who is still stuck in one and can't get out. So the other thing that patients can do is just advocate for themselves. Go after the insurance company yourself. The federal government isn't doing it for you. We're trying our best, but we're in a situation where something has to be done right now. So what we have done is put together this toolkit. Those are the papers I handed out earlier to help patients understand how they can approach their insurance companies and their employers, explain what's going on, and say that they want to be removed from accumulators. The very first step is to go, I tell patients, is to go to their HR department and ask their HR department, does our insurance program include an accumulator? You can expect that they will say they don't know, because in the vast majority of cases, they don't. These programs are new, they're complex, the nomenclature is very confusing. And HR departments typically just don't know. I can tell you Johnson & Johnson's own healthcare plan had an accumulator, and they only just figured that out recently. They're endemic in the market, but they're not talked about. So assuming your HR department says, well, I don't know, or I don't think so, we have information that patients can give to their HR departments explaining what's going on and asking the HR to go advocate for the people that they're insuring. Assuming that's going to take a while and it might be frustrating, patients themselves can approach their insurance companies. The first thing you have to do is figure out if whether or not the plan you're in has an accumulator, which is maybe not that simple. We know 83% of the plans have them, and you need to know if you're in one of those 83%. Look through the information that you were given that explains the program when you signed up in open enrollment, and look in the fine print for how they're talking about how coverage for medications will cost. What the accumulators are being talked about in various different forms. These are the three largest health insurers in the country. It's United, Cigna, and Aetna, I think. This is how they say what they're talking about. One calls it an out-of-pocket protection plan, which really it's not. True accumulation, okay, what the heck is that? Or coupon adjustment benefit plan protection program. If you see those words, you have an accumulator. So let's say you figure out you have an accumulator, you want to get out of it. What do? You approach your health care plan. This is what we have in the What Patients Need to Know document. Talks about the steps that you can take once you figure out you're subjected to one of these. What you want to do is get in touch directly with your health insurer and tell them that you're aware that these accumulators are illegal, they're no longer allowed, and you insist on being removed from it. You insist that they follow the federal law. I've had patients tell me that their insurance program, first of all, doesn't know what they're talking about, and second of all, they have to call back, and then that, this happens a lot, then they'll try to tell you, well, if we do this, it's actually going to cost you more money. You're going to pay more out of pocket. That is exactly not the case. Or if you do this, then that medication will no longer be covered. That is not the case. That is not true. So say, no, I know that's not true. I know that's not true. There's a letter in there, a draft letter that we have that you can send to help you speak with your insurance company. Now, what are you going to do? Because we're thinking down the road and we're trying, how can we help patients? It's likely that United will come back and say, you know what? No, I'm not going to take you out of the accumulator. I don't want to. Sorry, not going to do that. What do you do then? They just told me to go pound sand. What do I do next? This toolkit was developed in a partnership with the AIMED Alliance, which is a group of lawyers that approach healthcare from a legal point of view. And it's good to have them in our case because I found out things like I couldn't put down in writing which insurance company uses which name because you can, defamation or something? I don't know. So, but they have this program set up right now specifically for this purpose to help patients. You go to www.coveragerights.org. There, you can get in contact through there through either email or phone calls, and they will take your case and appeal it to your state insurance commissioner. We know the federal government isn't doing anything, so now we're going to go to the state insurance commissioners who can choose to enforce the ban. When you talk with the people at Coverage Rights, these are the types of things you're going to have to know. And hopefully write this down when you talk to your insurance program, when you call them. Write down, first of all, the day that you called, the time that you called, who you spoke to. The lawyers are going to want to know who is the complainant, that's the patient, be it yourself, your family member, whomever. The name and type of insurance you have, the policy number. I personally have Aetna HMO, I would say, and my policy number is XY. All of the party involved. This is when you need to know who is administering your pharmacy benefit. The majority of plans have what are called pharmacy benefit managers. These are separate organizations that administer pharmacy plans for them, the billing and the coverage and determining what's on formulary. And they may be called something else. If you're in United, their PBM is called Optum. So if you know the name of the PBM that's administering the program, it would be good to put that in. They want to know the state where your insurance is purchased. This is important because your state might have already passed laws on this. There are 19 states that have passed accumulator bans. I'll get to what that means in a moment, but they're going to need to know that. They want to know the claim information, what exact claims have been subjected to the accumulator, the claim number, the dates, and the amount in dispute. The reason for your complaint, that is, I want to get out of the stinking accumulator and my insurance program won't let me do it. And what you consider to be a fair resolution, and that would be, well, I want the amount of money that was spent on my behalf to go towards my deductible and copay, and if I've had to spend to reach that again, I want that back. It's frustrating that we're at the point where patients have to do this themselves. What is the best option now is that we pass the Help Copays Act, which I think Dr. Shaw talked about earlier. What this would do is change actual federal law to say that any funds expended by a patient or on their behalf should be counted towards their out-of-pocket requirements. This is needed because, first of all, it will make HHS enforce the ban that they should be enforcing already, and it'll take it out of the realm of regulation, so each administration can't continue playing political football with this. They can't mess around with it anymore. If it's law, and the federal government has to follow it. The other reason why it's needed is to help people in states that haven't passed the copay accumulator. Well, let me talk about that a different way. So there are 19 states that have passed copay accumulator bans. And you might live in one of those states and say, oh, this isn't a problem. I don't have to worry about this. My state already took care of that. Maybe not. And that's because the plans that are covered by state laws are only state-regulated plans. And these reach a very small amount of the population. Depending upon what state you're in, that's 20 to 30% of the insured population is covered by a state-regulated plan. These would be state plans themselves. That means somebody who works for a municipality, a county, or the state. Think like firefighters, police officers, people like that, who are in plans that are sold by the state, and certain other small benefit plans. If you're in one of those states that's passed an accumulator ban, but you are not in a state regulated plan, meaning if you're in a plan, an ERISA plan, a large group plan, an ACA plan, the ban doesn't reach you because it can only touch state plans and not federal. So by passing the federal law, we're going to cover everybody and not just who's covered by the state plans. I think there was a question. That's the end of my official presentation. Yeah, no, we've got plenty of time. Well, does anybody have a question about, because maximizers might confuse people, so let me just ask this first.
I guess, because I was out on workman's compensation, and now I have a state card, so it covers it, but I still pay out of pocket, like, astronomical costs for just about everything. So it's like other issues besides the GI stuff, because I can't take that medicine. I have like 18 allergies to medicines and other stuff, so the workman's comp. I'm officially retired, 62 this year, my birthday, February. So I'll start getting my pension, but I still pay for everything, every doctor, every specialist that I go to, because of the allergies or something like that. So the costs are like for dentures that I gotta get because I'm allergic to like the medicine or whatever. The estimate cost is like $2,500 already. That's just to make it, and then all the specialists or whatever. Like for specialized shoes and stuff like that, $500 or whatever. So everything that I have go to paying into that, so would it kind of cover me or whatever?
Just for people who are recording, the question is, what if I have workers' comp that's administered by the state? Am I reached by a state ban? The absolute truth is, I don't know. Coverage rights would know. What would make sense is that the workman's comp should be based on the insurance program that you had when you were employed, I believe. So I think it would depend upon who your employer was at the point when you became disabled.
The school system here, as well as Connecticut, so it's 2 states in a battle. Original state, home state is Connecticut. I worked here at DCPS. I got injured here severely. I had to go out in Shelby, which the Chancellor Ocean and stuff, whatever. So it was like the GI is a major issue, so you can't eat or whatever and stuff. And then it was the feet, which is trench foot and just other stuff, just not personal. But I have 18 allergies, so that took into the effect of what can we give her to help her because of the allergies to the medicines, to environmental stuff, and to food.
I can tell you, regardless if you're in a state that has passed a copay accumulator ban or not, if you're not, then you're in one that's covered by a federal plan. And as of the ruling, this court case, that means that you should not be in an accumulator. Either way, accumulators should not be used. Is who you would appeal to is the problem. So the first thing to figure out is whether or not there is an accumulator. If there is, then you approach the plan and say, hey, I know this is illegal, take me out of it. If they say, no, we won't, then you go to the lawyers. You go to coveragerights.org. The remedy is the same. Accumulators should not be used right now, and you should be able to be removed from it. This gets me to maximizers and what's going on.
One thing, Aaron, really fast. The lawyers that are in the coverage rights, those are completely free to pay.
Oh, yeah.
Like,
Oh, yeah.
They take no cut.
Nope.
You pay them nothing. They will just argue on your behalf to try to get you taken out of the accumulator. Because when you think lawyer, you're like, oh, well, what are they going to take? They take nothing. They're agreeing to do this for free for patients. I mean, eventually they'll get something, I'm sure. But they're lawyers, right?
I think I know where their funding comes from. The point that was just made for people who are recording, if you go and use the the resources from AIMED Alliance and CoverageRights.org. It is completely gratis. It costs nothing. They're doing this because they think it's the right thing to do and that accumulators should not exist. I can tell you, just as an aside, even speaking with the PCMA, the Pharmaceutical Care Management Association, and that's the trade association for the pharmacy benefit managers, they tell their members, you should not be using accumulators. This is abusive. It's a bad idea. And now it's illegal. Everybody believes insurance companies should not be using these. And I'm digressing myself. As I said, the need now to solve all of this permanently is to pass the Help Copays Act. Where we are with that bill, I don't know how far Dr. Shaw went into this, is we're trying to get more co-sponsors. If in a perfect world, we got the best of what we could ask for, we would get this attached to pharmacy benefit manager reform legislation, which is currently very much alive in Congress. It's happening. Through this Congress, last year and this year, 5 committees have developed their own pharmacy benefit manager reform legislation. They've all had hearings. There's been talk. There's been technical assistance. The bill is pretty much ready to go. We thought it might be passed at the end of March, but there were complications with leadership negotiations, and pretty much the House can't do anything right now. So it didn't happen. So the pharmacy benefit manager bill has now been kicked to the lame duck. And we really do expect it will pass then. There are numbers of reasons why. First of all, when you're in the lame duck, you're no longer campaigning. So whatever guff you might get politically about this is gone. The House won't be actively trying to oust their speaker. They'll be organizing for the next Congress. And a number of members of Congress who have a personal stake in the issues are retiring. So this is their last chance to get PBM legislation reform done. If we could, what we want to do is get the Help Copays Act attached to that bill. We tried earlier when this was being cobbled together. The problem was that the bill was scored to cost $10 billion over 10 years. And this Congress doesn't want to spend any money. The reason why it would cost money is because federally run programs, things like Medicaid, would actually have to stop using accumulators, and that means that they would have to pay more out of pocket because they're not double dipping, and so the federal government's going to pay more, which they don't necessarily want to do, although with the NBPP, maybe they're beginning to see the light. But now that this court case has passed, accumulators aren't allowed anyways, so there's no change, theoretically, to current practice, so this really shouldn't cost hardly anything at all. The score should be new. What we need is for the Congressional Budget Office to give us a new score. The best thing that we can do, I'm being a broken record, but is go back and demonstrate a large groundswell of support for copay accumulator bans by passing the Help Copays Act. Now let me get to maximizers. Just last week, the Department of Health and Human Services put out their NBPP 2025, the National Benefit Payment Parameter document. This regulates how health plans must work in order to meet federal law. They did not address copay accumulators in this, largely because the rule was baked before the court case was done, and they don't want to spend more money. HHS says they're going to do a separate rulemaking just on accumulators. But they did talk to maximizers, and it's good news. So people know copay maximizers are even more complicated than copay accumulators, but they do the same general design is the same, is that the insurance companies take money from the assistance and do not credit it towards patients' out-of-pocket requirements. The way it happens, and I can go deep, but I'll try not to, a health plan will remove a specific medication, a high-cost one, from the list of essential health benefits. From that in their plan, they'll make it a non-essential health benefit. When they do that, they remove that medication from regulations over cost sharing. In practice, what that means is then the insurance program will set the patient's out-of-pocket requirement to the exact amount of the maximum the copay assistance program is willing to pay. So they say, hey, you patient, all right, we're going to take Humira out of your normal plan, make it non-essential. When we do that, then we're going to go directly to AbbVie, and what your copay or deductible is going to be is exactly the amount that they're willing to give out in assistance. And don't you worry your pretty little head about this, because we're not going to charge you anything, or maybe just like a $5 or $10 copay. We're just going to go get it from AbbVie. And PCMA has said that this is what they preferred the PBMs would do, that they think this is a better practice than accumulators. But it's not exactly great. There's still a number of problems with maximizers. First of all, being that money doesn't go towards your deductible or whatever else. And so if you have another high-cost medication, or if you need diagnostic services or anything else medically related, that money that's being handed back and forth has no benefit to you, because it still has not counted towards your deductible or out-of-pocket maximum. So you still have to go and meet that again. And just what's happening in the larger ecosphere out there is these maximizers are soaking so much money out of the assistance programs that they're being reconfigured. Johnson & Johnson, as of the beginning, I think it was 2023, reconfigured their patient assistance program, so now it has means testing, and it never used to. Just because they're trying to stop the bleeding, what's going on here. So that's just not good in general. I know the GIs I talked to said their standard practice was to put every single patient, regardless of their income, through the assistance program and try to get it for everybody. And now a large number of those people aren't able to receive it. So, okay, that's the status what we're in. The FY 2025 NBPP came out last week. Now, this addresses small and individual plans, not ERISA, ACA, or large market plans. That's for, I'll tell you why in a second. But what it said basically was anything that's covered, any medication that's covered by an insurance program has to be considered essential. And therefore you can't move it out, therefore you can't have maximizers. So they removed maximizers. They said you can't use these. No, not allowed. So that's great. As of January 1, 2025, they're not going to be allowed for those plans. This did not reach the other larger plans because they have to run that regulation through the Department of Labor in addition, because the Department of Labor administers ERISA along with them. So the two have to come out with a joint NBPP, which is going to happen sometime this year. We don't know when, and we don't know when they're going to make the date for when it applies. It might be that they remove them as of 2026. So, but maximizers are being talked about and they're being addressed, and that's going to be solved soon. And you would hope that this means that we're going to get good news on accumulators, and maybe HHS is seeing the light, and they're going to do the right thing, but we don't know. They're not enforcing the current regulation. There's no way to know. So everybody's trying to figure out what's going to happen in the pharmacy benefit manager program. One thing I think is interesting, when you're talking accumulators and maximizers, a rational mind and a rational company would understand that these things are not good in the larger scheme of things, because let's say you have somebody who's in remission, who's taking Humira, and they're doing fine. Then you come along and you put in a maximizer. I don't know, maybe you put in step therapy, you put in prior authorization, something that disrupts the patient's access to that medication. Oftentimes, and we've seen if it's more than $250 a month, patients just stop taking it. Or they'll opt for a different medication that does not work as well. Then what happens, logically, is there are health complications for this. That patient then might be hospitalized, they might have surgery, they might have a fistula. And these things are going to end up costing the healthcare system as a whole more money. Why in the heck, then, do these things exist? And part of the problem, and part of what's driving pharmacy benefit management reform, is because the way the system is set up, it's siloed. Your United Healthcare, who is implementing all of your pharmacy stuff, is Optum, and they only do pharmacy. They're paid by being able to spend less on medications. They get direct rebates. The way they paid, we pay less for medications, and that's it. They don't care about the medical consequences because that's somebody else's problem and that's somebody else's paycheck. It's not theirs. It's just medications. So there are perverse incentives throughout the entire system for what would make sense, even for the insurance company itself, and for patients as well. Is there another question?
Has your organization given any thought to advocating for a single-payer system?
Yeah, I would love to have a single-payer system. It would make a lot of sense. It would be like Europe. And it would have access to medications, and we could move people directly to biosimilars without a bunch of guff. It is politically suicide to say that in this environment. The only members of Congress who talk about it is Bernie Sanders. It's anathema. Even a member of Congress who knows that makes sense wouldn't do it. There are two behemoths, lobbying groups when it comes to healthcare. And they're roughly equally matched in amount that they can sway Congress. You've got the pharmaceutical companies and you've got the insurance companies. And both of them hate that idea. And when both of them hate it, it's not gonna happen. I wish it could, but we're years from a system that is that rational. Is there another question? All right, I think I'm done.
Wow, with 3 minutes to spare.
There we go. Thank you, and yeah, good luck tomorrow.
So again, thank you to Cecile and the organizers for inviting me. It's really a pleasure to be here. I got the added bonus of seeing Sting's Message in a Bottle last night, the musical that was put on at the Kennedy Center, so an added bonus to being here. So I'll dive in. What I thought I'd title this is Common Sense Advocacy, because to all of us, you know, whether we're patients or doctors, when we come across this is common sense stuff. It's incredible that we have to fight for this legislation to get there, but hopefully all your efforts will make a difference for patients who are suffering and make it better. So with that, I thought I'd start about the background and why is this so important. Well, healthcare costs in the United States, and this is data from the AMA, are really huge. In 2021, that's the latest data I could find, but it's still gone up $4.3 trillion, or over $12,000 per person. And that accounts for over 18% of our GDP, compared to 19.7% in 2020. And several years before that, it was only 16%. So you can see that that's not sustainable, and that can't keep growing. The average salary, this is based on data from the U.S. Bureau of Labor from 2023, is $59,000. Now, to remind you, ACA, or Obamacare as it's called, expanded healthcare access to get healthcare access to more people within the United States. And there's been a trend by insurers to shift costs to patients, and that's been through co-payment programs. And they put it as a way to save money, but it can be a real burden in the way it's done. And it's important to realize that the U.S. pays more for healthcare than any other country, yet we don't necessarily have better outcomes, and our patients, our Americans, end up spending more in terms of things out of pocket than in other countries. So this is from this foundation, just looking at healthcare costs, how they've grown from 5% of GDP in 1960 to close to 20% in 2024. And this is prescription drug expenditures in Medicare. And this kind of parallels what happens in commercial insurers, but you can see how much money is being spent. And then compared to what other countries pay, we can see what we pay much higher. And even when we're comparing to westernized countries, we're not talking about countries that are economically disadvantaged, but sort of our peers. So we're spending 2 to 3 times. So where does all this money go? Feel free to interrupt me if you have questions. So about a third of it goes to hospital care, 15% to physician services, and then you can see in terms of home health care, nursing facilities, et cetera. What about who's paying for it? So private insurance pays about 28%. CMS, organization that takes care of Medicare and Medicaid, takes almost 40%, and you about 10%. And you can see the breakdown. So what are these copayment accumulators? So most insurances have a deductible, and it varies anywhere from $2,000 to $10,000. And for example, I'm experiencing this now with my kids and myself. We have a $5,000 deductible. So this year, until I get to $5,000, I've got to pay out of pocket. And once that's reached, then everything else is covered. So, and most of you experience this. After the deductible is met, the insurance fully pays for covered services and medicines. So what you pay in copayments, testing, procedures, etc., count. And this has included copayments made on your behalf by copayment programs via pharma. So for example, if you're on expensive medicine, let's say for inflammatory bowel disease, you're on a biologic, those medicines typically cost tens of thousands of dollars. And if your copay is $1,000, but the copayment program is picking it up, that would count towards your copay, usually. So why have the insurance agencies or the insurers put in copayment things? Well, they want to reduce cost and utilization, and they want to keep your premiums down. At least that's what they say. And they incentivize employers to choose deductible plans with the idea of saving money. Most commercial insurers, again, have those deductibles. And again, that's my payment is individual $5 and overall $10 for the family. So the copayment accumulators track the money paid by copayment programs. But the thing is, they don't count towards your deductible, so they're double dipping, basically. So the insurance gets paid twice through the copayment programs. And the other thing is that Medicare and Medicaid won't allow you to utilize copayment programs. Now, Congress did this thinking that if they allowed that to happen, that people would have an incentive to choose expensive medicines. The reality is our patients who are on Medicare and Medicaid, if they don't have access to the copayment programs, they can't access those medicines because they're just too expensive. And there's money from you. So this ends up leading patients not taking their medicines because they can't afford them. And that increased costs because they end up in the hospital because they're not on the medicines. And then there's lost time from work, the suffering, et cetera. So in terms of 2023, you can see all the different states that had copayment accumulator policies. As of 2022, there were 14 states that have banned copayment accumulators. And if you're not in a state that hasn't, you should be aware and push that. Now I think it's risen to 19 states now. And so this is important not only at the federal level, but at your state level. So when you reach out to your representatives, ask them if your state doesn't have it to consider sponsoring legislation and work with the local state legislatures to do that. So how do you know? You can ask, and these are the states, and this is the latest data I could find as of the summer of 2023, 19 states, including I think that the District of Columbia banned copayment accumulators. But they may not apply to the New York copayment maximizer programs. So if you have a health benefits manager at your employer, just consult with them to see if that applies, and then ask them to choose a plan if they can that doesn't have that. And if your state doesn't have that legislation, that's an important thing to push at the state level as well as the national level. So what can you do? Well, when you're on the Hill, please make sure you mention the Help Copayments Act. You've got a great handout that's already there, so this is already there. And basically, it just simply requires health plans to count the value of copayment assistance towards cost-sharing requirements. And then you can amplify your voice by getting your family and friends. They know what you're going through. You can amplify that voice. Congress is very reactive to the number of people that complain about things or are concerned about things, and especially if they're constituents who vote. And so it's important when you go to say, hey, I'm from your state, blah, 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 and your district, and this is important to me. You already know to contact. Don't forget about, again, the state level, and then, again, your benefits manager if you're employed and you get your insurance through your employer. Now, whenever I've gone to lobby Congress about anything, one of the things that always comes back is cost, right? Okay, this sounds good, but what it's going to cost. And what's great is that this does not, there's a nice study here, and you can quote, that does not increase the cost to the healthcare system. So really important. So these are some of the resources, and the IFFGD IFFGD website is excellent, and there are several others, including the DDNC. And just so you know, the American College of Gastroenterology will be here starting Wednesday night, Thursday, Friday, lobbying Congress, also about copayment accumulators and step therapy and some of the other things. So we'll be able to hopefully amplify each other's voices in this process. This is really common sense legislation about who controls your health care. I have this radical notion it should be the patient and their doctor that decides what's best for them and not a third party that's not really interested in it. And I think most of the congressional delegates and their staffing agree with the understanding that we have to control costs just the way things are. So these are some of the other things that you guys are going to be talking about, and I'm happy to talk in detail about them. So the Safe Step Act, and we'll talk about that in detail, but that's, again, letting you and your doctor choose the best therapy for you and not letting the insurance company choose it based on cost alone. And there's common sense legislation, for that if there's data to support it. It also makes it so that the insurance can't drag their feet. And unfortunately, I deal with this all the time, but we've seen patients who are waiting weeks and months to get something approved because the insurance is delaying, hoping that they're going to go away. And it's almost a tactic that's almost implicitly in there, knowing that a lot of patients and doctors aren't going to fight and will settle for the lesser medicine or just wait until something else happens. So we'll go through the Reducing Medically Unnecessary Delays in Care Act, which is sort of similar. There's the Treat and Reduce Obesity Act, Medical Nutrition Equity Act, Medical Nutrition Therapy Act, Food Labeling Modernization Act, Liver Illness Visibility Education Research, and finally a grant to increase colon cancer awareness. So let's talk about Safe Step Act. And this has been introduced several times in previous Congresses, so the representatives should be well aware of this legislation. And the more co-sponsors we get, then the more chance it's going to pass when the right legislation applies. I think this is really close to passing. So if we can get enough sponsors, both in the House and Senate, it'll probably be tacked on and passed. So the problem with these prior authorizations, it doesn't. It's really designed to decrease costs for the insurer, and it's sometimes cloaked as quality. So the insurers will say, "Oh, we want quality stuff," but it's really about cost. Because when you point out the data, you usually get it reversed, but you have to go through that process. So these result in delays of weeks and even months. And again, unfortunately, most patients and doctors don't know they can fight it, or even if they know, don't have the time. And you might be a patient with illness, you've got enough going on to have to fight the insurer to get the improvement is difficult. And for a doctor who's busy, it's hard to take the time to take the call, write the letter, do all that stuff. And this is all time that is not reimbursed. So it ends up being a burden. And I'll show you some data from the ACG about how that leads to burnout amongst physicians and in terms of time. And it clearly negatively impacts patient care. And so what the Step Therapy Act, it's clear and transparent process to include an exception and requires to grant acceptance if a certain protocol is met. So basically, if there's good data, if there's guidelines that show that this drug is appropriate and FDA approved, it should be approved, and they can't delay forever, so they have to respond. The other thing it tries to do is, I get frustrated when I talk to a nice doctor who's on the other end, but they're a family practitioner or OBGYN or a cardiologist. They know a lot more about cardiology than I do, but I know a lot more about GI than they do. So we consider a peer-to-peer review when we're talking to somebody within our own specialty, so we don't have to go through and educate them about that. So that's another part of that bill. So this is a survey from a couple of years ago that my colleagues did that was published in our journal, the Red Journal, American Journal of Gastroenterology. You can see the burden associated with prior authorizations in practice is really high. In my practice, there are 9 doctors. We have 2 physician assistants, and we have a whole staff. I have 2 staff members. Their full-time job is to do prior authorizations. 2 staff members. And it takes that time. And they're really good. But still, I have to get on the phone, and then we have letters and stuff to do. And you can see how many times a day or week impacts. And this just shows in terms of, I'm sorry, this is a little bit busy, but what it's showing is that because of this, doctors are choosing drugs that they don't have to fight as much for, or they would prefer to choose the other drug, but they're like, well, if it's going to take 2 months to get that approved, are we better off just trying this one? I'm choosing a drug that's less good, or I'm not even going to bring up that other drug as an option because I don't think it's going to get approved by the insurer. Now, the Crohn's and Colitis Foundation, other organizations, the ACG, we have pre-formatted letters. In fact, we just finished updating those letters for biologics that we're going to have on our website so that a doctor can just take that letter, quickly customize it, and so it's pre-formed for all these different scenarios. But it's still another step to do. So, any questions about that?
I just have a question. So from my personal experience regarding different insurances that I've had, there's a lot of medications like Motegrity that are non-formulary. What exactly determines whether a medication is in the formulary or not?
Yeah, that's a great question. So the question is about formularies. And so an insurer goes through the available agents and then chooses what's on their formulary based on a couple of things. So they need to have a certain amount of drugs, for certain conditions, and their criteria usually has to be FDA approved and data to support it, and then they tier it. And so if they have drugs that are, and part of it makes sense, if they have drugs that are equivalent but one costs a lot less, they're going to put that one first, and they might tier it so that tier 1 drugs have a lower copay, and then tier 2 drugs have a higher copay. And they might say that, well, before you go to the other ones that cost us more and cost you more, you need to try the one that is less costly. So, new drugs usually don't get on that formulary until they've been around for a little bit. And to get on the formulary, not only does it have to be FDA approved usually, but they have to have a contract with that insurance company. Now, sometimes the insurance companies will say, well, we're not in charge of that. We've sort of ceded that responsibility to a PBM, or pharmacy benefits manager. And so the PBM does that. So there's another layer too. And what Congress is finally looking into this, but the PBMs don't have to disclose their deals. So they may have a deal, so they're getting a kickback from drug A, and drug B may be better and maybe cheaper, but they're not getting the kickback, so they don't put it on their formulary. And they say, well, we have one drug, that's good enough. And that's very frustrating. And so then patients and benefits managers have to advocate, for that. And so that when you're looking at your insurance program, you have to see which drugs are covered and what applies to you. I do this now, or I try to help my mom with this. She's got RA, and she's on a Medicare program plus a supplement, and so she chooses the supplement based on what the coverage is. But it has to be reevaluated every year, and it's a very complicated process. So even if a drug's out there, if it didn't make it to that list, then it's inaccessible until that happens.
Yeah, because specifically like for the mechanism of action,
Right.
sometimes they recommended like laxatives and like senna and things like that, but
Right.
it doesn't work the same way.
Right, and so what we have to do in that scenario is we'll say, you don't have this mechanism of action. The patient's tried these other drugs and failed. Please approve and put them in that tier, and then sometimes we can get them there. That's a harder one to fight, but we do fight that. With the other biologics, usually if we fight 90% of the time plus, we're able to get approval. But it takes that fight. And there's legislation that you may have heard of called Gold Card legislation. Have you guys heard of that legislation? It's passed in Texas. We're trying to get it in other states and potentially nationally. But the idea is if you can show that you're winning 90% of your appeals, then you don't have to stop. You don't have to do the appeals anymore, because it's wasting everybody's time, and then you just sort of get that. We've also tried to do that with the insurers. We've approached, for example, in Blue Cross Blue Shield, Rhode Island. We said, you're spending a lot of time. We're spending a lot of time. If we show you we're following the best guidelines and we're trying to reduce costs and we're using biosimilars where appropriate, et cetera, can you get rid of all the prior authorization stuff? And so we're not having to spend, our staff spend time and your staff time denying. We can just get the patients the care they need. And so they're open to that. They want to track cost to that. But that gold card legislation would be huge, because then we can focus resources more towards patient care and less towards fighting for coverage. Gold card legislation is the way. I don't know if any right now nationally, but a lot of states have it.
And just to let you know about the insurance coverage, this is a question that's come up in our advocacy meetings. And so later today, Alyssa Sutton is actually doing a breakout on insurance coverage and what all of that means, and how to navigate picking a good insurance and how to navigate the appeals process. And so that'll be a great breakout session that I think will help answer some of those questions for you this afternoon.
Thanks. So let's look at the other ones that you're going to be advocating for potentially. Reducing medically unnecessary delays in CARES Act. And this is sponsored by Representative Green from Tennessee. And I'll just quote him. And I mean, this is common sense to all of us, right? A physician should be the one determining a patient's course of treatment, obviously, along with the patient. Prior authorization is a roadblock to care, equivalent to a bureaucrat in the waiting room. Medicare and Medicare Advantage plan administrators should not be able to exercise a unilateral veto over a doctor's prescribed treatment. It is this kind of red tape that creates frustration for healthcare providers and patients alike. We know that prior authorization leads to delays in care and worse healthcare outcomes for patients. At times, to put patients first, pre-authorization doesn't do that. So basically, this will apply to all Medicare and products and Medicare supplements, and so a huge reach if we can get that passed. In terms of the Treat and Reduce Obesity Act, we know that obesity is a huge problem, and unfortunately a growing one in the United States. And for the first time, we have a bunch of drugs that are very effective in treating obesity. They're very expensive, though, and are not affordable by most people if it's not covered by insurance. So this directs, basically, number one, Medicare to cover these agents to treat obesity, and also improves access to behavioral health to go along with the drug therapy. So these drugs don't work if they're done in isolation. They work best if they're done along with behavioral therapy, nutritional support. And so it's sort of common sense legislation. We know that if we treat obesity and improve obesity, that there are downstream cost savings. So this is cost effective as well. So the Medical Nutrition Equity Act. So drugs are covered if they're FDA approved, but they have to go through a whole process for FDA approval, usually 2 large randomized controlled trials showing their safety and efficacy, and then the FDA considers approval for that drug, and there's still ongoing safety monitoring. For these certain nutrients, for example, it could be nutritional support in the form of formula. Let's say there's a product called Kate Farm supplements that are plant-based proteins that are popular by a lot of patients. They're very expensive if not covered by insurance. And they fall into a category where they're not a drug, but they're not just food that you buy. And so patients are left struggling how to get these things. There are data that show that these things work and can help in certain situations. So, for example, some of our patients with inflammatory bowel disease need to be on these nutritional supplements, but they're unaffordable without medical coverage. So this ensures that there's coverage for medically necessary foods as a treatment option. And again, the coverage is the issue. The Medical Nutrition Therapy Act is sort of similar. It is a little bit more broad. It covers medical nutritional therapy for diseases, a variety of diseases that can cause unintentional weight loss. So it could be gastroparesis, it could be celiac sprue, it could be inflammatory bowel disease, it could be a variety of things, not just GI. It could be cardiovascular issues that lead to it where you need nutritional support. And it allows not only physicians, but nurse practitioners, PAs, clinical nurse specialists, and psychologists to refer if they see a patient who's nutritionally at risk, to refer, for the appropriate treatment. The Food Labeling Modernization Act is really very simple. We've come a long way in terms of labeling foods for safety, especially for our patients with celiac sprue who need to avoid gluten. And when I first started, it was very tough, and I'm going to date myself. I finished my fellowship in 1997, and it was very tough for our celiac patients to figure out whether there was gluten in foods because they weren't labeled very well. And when when they went to restaurants did not cater to them. And so, food, and those of us who went to dinner last night, food is such an important part of our social fabric about connecting with each other. If people aren't able to do that, that really is a huge impact on their social life, on their overall well-being. So by increasing the labeling, you basically make it easier for people to be a full part of society, whether that's going to the grocery store or going to restaurants and being able to enjoy and get that. Interestingly, things have really improved, but still we have room for even more improvement. Now the labeling's much better, and there are about 4 to 5% of patients in the U.S. who identify as gluten sensitive. So they don't have celiac sprue, but they feel that they don't feel as well on gluten. So they've pushed for being gluten free, and that's resulted in benefit for the people who are celiac. And because a lot of restaurants realize that they're going to gain more business if they can have a gluten free diet or gluten free options on their menu, and supermarkets and all that. Before it was only specialty supermarkets, but now all the supermarkets have that. So I think this is sort of a no-brainer. Doesn't really increase cost, and makes it easier for patients to follow the diet that they need to for their health. So finally, tell your legislature to push HHS. So HHS controls Medicare and Medicaid, and we've come a long way in terms of colonoscopy. So the ACA Act, Obamacare, mandated that all screening tests be covered. So colonoscopy is now fully covered, and that's been huge in decreasing the burden of colon cancer. So colon cancer, it's a tragedy when I find somebody with colon cancer, because I think, my gosh, we should have prevented this. If they come for screening, we should be able to prevent 90% of colon cancers from happening. So the age at screening used to be 50. It dropped a couple years ago to 45. So patients can access screening, and it should be covered 100% starting at age 45. There's no longer a polyp penalty for our Medicare patients. We fought for at least 15 years to get that through. So the other lesson I would tell you is don't get discouraged. It takes a while to get things through, but we finally got that through. So now when our Medicare patients go for a colonoscopy, they're not worried if we find a polyp, they're going to get a copay. It's fully covered. There's two-step screening is now covered. So before, a screening colonoscopy is covered if that was your first test. But if you did a FIT test for blood or did a Cologuard test, then went for a colonoscopy, they say, oh, nope, colonoscopy is diagnostic, and now a copay applies. We finally got rid of that, so that's part of the spectrum of screening. So if you do that first test and that's positive, the second test is automatically covered. So that's a nice step forward. But what happens if you have a polyp on your colonoscopy and need to go back sooner than 10 years? So we have certain rules and guidelines depending on the number and type of polyps, we find how quickly to go back. So that second colonoscopy, 3 or 5 years later, copayment applies, and that can be a discouragement for patients to go, and then they wait, and they might end up with cancer, and we don't want that to happen. So when we got into Congress, for that, they said, well, we don't have to do anything. HHS has the authority to just approve that. So we're trying to get them to do that so that patients don't have a financial reason not to go for their screening and then surveillance to prevent colon cancer. It's great that we found a polyp, we removed it, we're going to decrease colon cancer risk, but if they don't go for their follow-up, that's a lost opportunity. And the other place this comes up in our patients with chronic inflammatory bowel disease, both Crohn's disease and ulcerative colitis, after about 8 to 10 years of disease, their risk of colon cancer goes up, so they need colonoscopies more frequently. But if it's not covered or there's a 20% copay, that's a discouragement for them to do that. So again, HHS has the regulatory authority to improve that. So, and you're going to get much better in this, and it's a great handout, but these are my sort of clinical pearls. So make it simple, and when you tell your story, and there's the KISS principle, right? So keep it simple, and I don't like the stupid part, but keep it simple. It doesn't have to be complicated. It's very straightforward to tell your story, and it's that elevator pitch, right? If you have 2 minutes to tell somebody in the elevator about what's going on with you or that thing, that's the pitch you want, and you just want to be very clear how it affected your health, your job, your life, and the people around you. connect with the legislature. Say, hey, I'm so-and-so, I grew up in the same town. It turns out we went to the same high school. They like that. They like that human connection. They get lots of professional lobbyists. You're going to be refreshing in terms of being somebody who's a real person in the community that they represent. Thank them for their time, and really important to follow up afterwards. Hey, thank you for meeting with me in an email afterwards. I appreciate that you're planning on signing on board, and this is to make sure if there are any other questions. If a question comes up that you don't know the answer to, relax. Say, hey, I don't know the answer to that, but let me check, and I'll get back to you. Simple as that. And then when you're going, and let's just rehearse with your group so things flow smoothly. So you're efficient with their time and your time, and so you can make all your meetings. Any questions about this? It should be very conversational, and those of you who did it before, I'm sorry, I know this is very, very simple. So this is an example from a few years ago. So this particular person, I had her come and testify or be one of our speakers at the DDNC, and she was a medical student at the time. She's now a physician, and back at Brown, she went up to Boston for her residency initially. So she had Crohn's disease. She's given me permission to tell her story. So she was denied the right to the right treatment due to step therapy. So she had to be on drug A before she could be on drug B. She and her doctor knew drug B was the right drug. And the previous MD didn't fight the insured. I'm not sure why, whether they didn't think they would win or didn't have time. So she got on, the wrong drug. Didn't work for her. Got hospitalized with an abscess, needed drainage, needed steroids, missed several weeks of classes, had to make up the stuff. One of her advisors knew that I specialized in IBD and had her see me, and we instantly fought. We got her on the right medicine. Probably easier for me to fight because that's what I do, but she had already failed that other medicine. So within a week, we got her on the right medicine, and she's done great since. So, and on the right medicine, she's not been hospitalized again, and now she's an endocrinologist in the community. When she told her story, people were like shocked, like, why would this happen? This is somebody who's connected. She was a medical student. She knows the system. She had a doctor did the right thing, and still it failed. And that's what's so frustrating about the whole step therapy thing, is that we know the right move, but we still can't get it there. And so that kind of story, and we still keep seeing this happening over and over again, whether it's the delay to getting that first therapy or making patients fail the wrong therapy first. So I'll stop there. I've got 2 co-payment accumulators. So these are my twin boys from last year when we went college touring. That's Vijay and Anand. And so my co-pays are going to go up drastically in about 4 months when they start college. Vijay's going to be at Boston University and Anand at Skidmore. We a couple weeks ago got to see the eclipse. This is in Keysville, New York. We got our special glasses. Our dog wouldn't wear the glasses, though. And this is the eclipse picture that my son Anand took. You can actually see some of the flares from the corona coming out. So I want to share that with you. That's it. So I'll stop there and happy to answer questions.
The only thing I'll ask is, I saw you use payment maximizers. What's the difference between that and accumulators?
Yeah, so I've got to double check. So the copayment accumulators basically penalize the patient. Copayment maximizers allow you to maximize the copayment before, so I think that's okay, but I'll have to double check on that.
Okay, so with that, we're going to get started. My name is John Mahalchek. I'm a patient who's been doing advocacy work since about 2016. Really enjoy going up on Capitol Hill and getting to share our stories with the lawmakers. I always like to tell a little anecdotal story, but the first time I was on Capitol Hill and I went into one of these meetings for the first time, I was scared out of my mind. I sat there not knowing what to do, felt really unprepared. And then afterwards, the staffer came out to me and said, I saw you looked a little bit nervous, but you did great, don't worry about it. We're here to hear from patients. We care more from hearing from patients than we do when we hear from doctors and industry and things like that. We have the stories that they really want to hear. So I guess what I'm saying is, we got this. You'll do fine. Part of what we're going to do today is talk about researching our representatives. And the reason why we're going to do that, I'm going to show you why that's so important going into these meetings. We're also going to look at prior legislative sessions and how those can kind of help us be prepared for tomorrow as well. And then we're going to learn how to kind of make sure we're getting official information instead of other information out there about our representatives. And the biggest part, I'm only going to spend slides for like 5-10 minutes tops. The rest of the time, we're going to be using some of this stuff to prepare for tomorrow. So that's the biggest goal. So I kind of break this down into 2 different parts as to why this is important. The first is to create a memorable moment. The staffers that we're going to meet with tomorrow take advocacy meetings all the time. So we have to come up with a way to make sure they remember us. So we want to find a way to connect so that they can remember our asks and things like that. So how do we do that? So the first thing we're going to do is look at their bio, see if there's something we can connect with them about. It doesn't have to be healthcare related. So you may find out that they went to the same high school as you, lived in the same neighborhood, stuff like that. Anything that you can make a connection with. It doesn't have to be healthcare related. And then the other thing we want to know about is, has this representative supported any healthcare legislation before? That may give us a good talking point to jump off of. And then, have they supported our asks previously? So, as both of our previous speakers mentioned, some of these bills take 10, 15 years to get passed. We want to know, is this something they supported last session or not? And then, have they participated in any healthcare events? In their community, a lot of them have, they do the healthcare roundtable discussions and things like that in their community, something that would be good to know as well. The other reason this is important is because we want to be efficient. Most of our meetings tomorrow will be 30 minutes or less, more likely, because we still have to get there, we have to go between the rooms and everything like that, and it can take some time. So we want to make sure we're efficient with the time we do have. So if we find out through our research, and the IFFGD team already did some of this for us, we want to know, are they already supporting something that we were going to talk about? And if so, it's really important that we thank them for that, but we probably don't want to spend a lot of time talking about it because it's something they're already on board with. Have they supported this last session? So there could be some that signed on as a co-sponsor last session, but this session either haven't yet or in the process of signing on still. So again, we'll thank them for their support in the past and just ask them to continue to support it in the future. But we probably don't have to explain the bill in great detail because they're already going to know. So we're going to get this information from a couple of different places, the first being the official websites. So we want to make sure we're using these sources when we're doing this research so we have good information. We want to kind of stay away from the campaign sites and other third-party sites. We just want the information from the source. All of their websites will end either house.gov or senate.gov. So those are the ones we're going to look for. And when we get to the site, what are we looking for? Their bio and platform. Press releases they put out can be a really good source of information, as well as, and this is a big one, committee membership. So the laws will start out introduced in the House or the Senate, and then they move to committee where they have to get passed. So if we can find out if one of our members are part of those committees, then we can encourage them to help us move things along. Okay, so interactive time. So I think Cecile said you guys are all going to have phones, laptops, iPads, something like that. Does that mesh? She said she encouraged everyone to bring one.
Well, we were encouraged.
Okay, so we're going to do this together. That way you guys can kind of get used to it. So the first thing we're going to do is figure out who our representatives are. After that, though, we're going to go off the representatives on the list, because we may not have been able to secure a meeting with your particular, especially on the House side. Sometimes they just don't happen. So then after that, we're going to switch to the paper. That's why I handed those out. Okay, so, well, as I'm having trouble getting up on the projector, so basically the first website is just congress.gov, and then there's a Find Your Legislator link on it. And here you either put in your zip code or your address, and it'll tell you your 2 senators and your 1 representative. If you just do a zip code, sometimes you'll run into a situation where they give you 2 representatives, and that's just because there's 2 people that cover that zip code, so then you have to put in your full address to figure out which one's for you. Everyone found their members, so we're good. Now, in that same spot where you look them up, there should also be a link to their official website that's already there. So that's the next step, is to get to that website. And then once you're there, the things we're looking for is usually like an about near the top, there's usually an about drop down or something like that. And under there, you'll see things such as bio, committee memberships, things like that. Was everyone able to find that for their rep? Okay, so then once you find that, we'll take like 5 minutes or so, and you can go ahead and read through that and try to see if you can find that piece of information that we can use for that connection tomorrow that we talked about. So again, it doesn't have to be healthcare related. Could be same hometown, high school, something like that. Anything that you can relate to that we can use for tomorrow. That is true. Most of the time you're not. But what I found is that even with the staffers, they're excited to be able to report that back to their boss when they talk about the meeting. And actually, some of the best follow-ups I've had have been with reps or senators that I was able to kind of make that more personal connection with, and they were able to pass it on. And then that kind of encouraged the communication to stay open. But yeah, unfortunately, we won't be meeting with the rep most of the time. Every once in a while, you get a surprise, and they're there. Yeah, they walk into the meeting. And if that does happen, it is okay on Capitol Hill to ask for pictures. So don't feel worried to do that. Yeah, those are some of the best shots. And sometimes you'll learn about these connections at the meetings as well. I know we've had a couple meetings that I've been to, specifically with folks from Crohn's and colitis, and the rep or the staff member will say, "Oh yeah, the rep, my boss's daughter has Crohn's," or something like that. So you'll hear those things too during your meetings, and that may be a good thing to remember for next time, or for your follow-up letter. It's also good for that. That way you can keep that connection strong. Is there anyone who wants to share first?
Sure, I will.
Okay.
So I didn't really have to go online to tell my story. Mine is with Tim Scott. I don't like his politics, so I'm not going there. But he happened to have been at the Masters this past week, and he was with Tiger Woods, so I mentioned something about that.
There you go. Yeah, healthcare, I think, is hopefully one of the last bipartisan or nonpartisan areas. But see what happens.
That will be my icebreaker.
But that's a good, yeah, that's a really good one.
But also, if it's the same woman, Megan McCauley, happens to live down the street from where I live in Mount Pleasant.
There you go. There you go. You can always find something fun. Anyone else ready? So you guys are looking, I'll share mine. So my representative is, that we'll be visiting tomorrow is Chris DeLuzio. And actually, one of his election campaigns kicked off at the fire department I volunteer for. And I got to talk to him right before he kicked off about these healthcare issues. And then, ironically enough, a couple days later, he actually came to my house to keep talking about stuff. So that's my connection with him for tomorrow. Anyone else ready?
I have Eleanor Holmes Norton with Washington, D.C.
Okay.
I just put it in the question and meetings and stuff, and it's gonna be with regards to healthcare.
Mm-hmm.
Am I supposed to share something that I know about?
Just whatever you feel you can connect with.
It's gonna be about healthcare.
Health, yeah, that's fine. Yeah.
I'm trying to, you have to request a meeting with me. So.
Yeah, so that's so we don't have. So luckily, IFFGD staff and the firm they're partnering with have already took care of that part for us. So these meetings are already scheduled. They're actually on the paper I gave you at the bottom.
Okay. Well, it has Lucy Swartz and Joanne Kim and Hannah Kaufman.
Yeah.
DC and Virginia.
Mm-hmm. Yeah, so they may not have your exact person, but that's okay.
Okay.
Anyone else?
I think mine
Okay.
is Glenn Ivy.
Okay.
And he's on conferences for health. And I know I saw him yesterday at the Black Health Matter conference.
There you go. Very cool. Going to be a good connection. Anyone else want to share? So the person who's coming down after me is going to go over more of the meetings tomorrow in depth, but basically for the half hour we have, it's just really important that you have your specific story in mind going into it and working with your group to make sure everybody kind of knows what everyone's going to be talking about. So you don't have two people necessarily talking about the same thing unless they're both really passionate for it, and then it's okay. But if you can, it's better to kind of split it up a little bit. Make sure everything gets talked about that's important to you. Again, like Cecile said earlier, there's a lot of bills that we went over today, and we don't have to bring up all of them, just the ones that really hit home for you.
His office.
Mm-hmm.
Well, so will we be going to Longwood House?
So the meeting locations are on your paper already. So it'll have like your meeting time and location. But like I don't know if there's any, I don't remember if there's Texas, Georgia, or North Carolina in the room, but we were talking about how you have 30 minutes or less sometimes. Like you guys have back-to-back meetings in different buildings. So that's going to be an example of a time where you're not going to get your full 30 minutes. So again, that's just kind of why it's important to do this work beforehand so we can make sure we're efficient with our time while we do have it.
I'll go.
Okay.
So with Marco Rubio, we're both from Florida and the Miami region, and we're also immigrants. So I was thinking of using that as a connecting point.
Very good.
Yeah.
That'll be good. This just kind of helps the staffer when you're emailing them afterwards kind of remember who you were, who our meetings were, what we said.
Senator Van Hollen actually made a presentation to the American Gastrointestinal Association.
Really?
Some years ago.
That's pretty cool.
It was very, very compelling.
And
Yeah.
David Trone, I spent a lot of money at his store.
There you go.
What's the store?
He and his brother own Total Wine and Beverage.
Oh.
Interesting.
Yeah. I'm trying to remember who it was, but there was somebody that the DDNC brought to talk to us. I think it would have been 2019, and it was one of the most compelling talks I'd ever heard from a lawmaker, but I just don't remember who it was now. I remember the talk beautifully, but I don't remember who they were.
Well, this is not something with my person, but I
That's
always
okay.
thought I was in the 4th Congressional District, not 4th, 3rd Congressional District of Maryland, but I'm actually in the 3rd.
There you go.
No, I'm actually in the 4th. I always thought I was in the 3rd.
And not to confuse you, but for a lot of states, that's changing next year. So a lot of the new
Yeah, I
or
know that.
battled congressional maps are going to go into effect. Okay. In the interest of time, I'm going to go ahead and just go to the next part, but don't mean to rush anybody. We can keep working on the other ones at the same time. There we go. So this next one, remember earlier I said that prior legislative sessions give us a lot of useful information. So this is one way to figure that out. The site's called govtrack.us, and I'll pull it up on the screen here in a second. But basically what this allows us to do is put in the bill that we're interested in, and then we can see a complete list of all the co-sponsors, which again, IFFGD has done that part for us. They've already put down if their representatives are co-sponsors in anything. But it also lets us look at the same bill that was introduced in prior sessions. So we may find out that this person has not signed on yet, but they were signed on during the last session. And that can be really useful information as well. So let me pull it up. So now you can see my screen. So this is that GovTrack site that I was telling you about. So what we can do is up at the top is where we can put in the bill information. And most of the stuff that Dr. Shaw talked about this morning, those bills are in your packet that you got. So it'll have all of the ones that he talked about. Since Safe Step has come up quite a bit, I'll just use that one as the example. So what we'll do is go ahead and put that in there. So for Senate at 652, and again, this was govtrack.us. So here's the information. All I did in the top part right there is put in S652. which was the number of the bill that I chose for Safe Step Act. In the pamphlet, well, the pages aren't numbered, but it's right before the halfway point in the pamphlet. So like if you open up to the halfway point and then just go back a page, that's the one that it's on. It has IFFGD legislative agenda at the top of it. And it has all the bills and bill numbers in there. And little summaries too, so if you're overwhelmed with the amount of information, there's some more in here too. The key points. So here we can see who originally sponsored the legislation. And then the important part for us is co-sponsors. Right, so these are folks who have already signed on. So again, we can see here that like my Pennsylvania senators is already on as one of the original co-sponsors. So that'll be something good for me to know for tomorrow. So that's how we can look at co-sponsors. And then the other thing we can do is if we go back to overview.
What was that, the last one that you just said?
It was under co-sponsors. Under details, the other important thing is we can see right now what committee it's assigned to. So in this case, it's the Center Committee, the HELP Committee they call it, but Health, Education, Labor, and Pensions. And then if you weren't able to figure out who was on that committee, when you were looking at the background reasons on the website, when you click on that committee in GovTrack, it'll also tell you who's all on the committee. So that could be useful information as well. So it'll tell us what committee the bill's in, who is co-sponsoring it, what committee it was assigned to, and then we can find out who the committee members are. And if you're lucky enough to get to meet with somebody who's on the committee, it's really great to be able to ask them if they can help push it through the committee, because nothing will be able to get voted on until it goes through committees. So if you can, if you see that they're in that committee, it would be good to ask them to help move it forward and get a vote on it. So then we can go, the other thing we'll do is, I'll just go back. And then you can also see here, for instance, the Safe Step Act was also introduced in the House, and that's that version. So a lot of times bills will get introduced simultaneously in the House and the Senate, they'll work on them, and then they'll go up for a vote. So there's always a House equivalent, not always, most of the time. There'll be a House and Senate equivalent for the same bill.
As in they're introducing the same legislation in two different places?
Yep, just it speeds the process along, basically. So it'll get introduced in the House, go through their committee process. It'll get introduced in the Senate, go through its committee process. And then when they get voted on, they call it reconciliation, where they come together to make sure there's no differences, and they can vote on the final bill. And I didn't say it made sense, but that's the way they do it. Yeah. And then what also ends up happening a lot of times, I think they mentioned it briefly this morning, is a lot of these bills won't actually get voted on as the bill. They'll find another piece of legislation that's already going to get passed, and they'll attach it to that bill. We were talking earlier about how the Colorectal Screening Act finally got passed last year, and that was how it got passed. It got attached to a healthcare funding bill right near the end of the lame duck session, and they were able to get it through. So you'll see that happen a lot too, where the bill won't actually make it up, but a version of it will get attached to something else.
How many bills were passed per legislative session?
That's actually a great question. Julia, who's coming down here next, works for the company who helped us set this up, so she may be able to give you an idea on that. But I really don't know. It's a lot. But a lot of the stuff is they will do like resolutions for special events going on. there's annual stuff that has to get done every year to keep the government going.
And the legislative session is considered like a calendar.
Yeah, so it's the whole span of 2 years, right? Between, yeah, for the 2 years, and then they take a break or a recess in between. But the legislative session goes for 2 years. So this is the last year of the current session. Yeah, which is why we're hoping that things will get in the lame duck will actually get passed. Yeah, and so if this is the other thing that sometimes people find interesting. So let's say the bill doesn't happen, the session ends in December. When they come back, we got to start this process all over again. You have to find someone to introduce the bill, get all your co-sponsors again, get it through committee again maybe. So this is kind of like the last push. And that's why it's nice that, you know, we're going up to the Hill tomorrow, and then the ACG is going to be coming up at the end of the week to kind of help reinforce.
Why is it that you can't carry? Because is it like after? Are you saying that after a recess you cannot carry over legislative work?
So it's basically once the session will end.
Oh, once the session.
On the 31st,
okay.
Yeah.
But within the session, like that recess.
Correct. Yeah. Within the 2 years, you're fine. Okay. It's after that, going into the next session, that everything will reset.
And the session applies to the entirety of Congress or just the House?
The House and Senate are in the same session, yeah, for the 2 years. Yeah, they correspond with each other. Anyone have any other questions about that kind of stuff? No?
Does it also matter, say for example, if your representative is also, this might be maybe their last year?
Yeah, that's happening quite a bit. We have a lot of people retiring this year. There's two ways to look at that. The first is that they don't have to worry about the political side of things anymore because they're done. So sometimes they're willing to push things through that they would otherwise not be willing to. Sometimes it's just that they're done, and you're not gonna be able to convince them to kind of push things forward for the rest of the year. But most of the time, what we've seen in the past is people become a lot more open, I guess I'll say, when they know they're retiring. Especially if there's something that they really have felt strongly about that they haven't been able to get done. Sometimes they'll find a way to get it done before they leave. That's all I have for you guys. Again, the goal was just to kind of help us start thinking about tomorrow, finding out what we're going to talk about, making sure we make the most of our meeting time. Does anyone have any questions?
Well, I did this last year, and I was surprised that you don't always meet in their office. Sometimes
Oh gosh,
you
no.
meet outside in the hallway.
Yep.
Yes.
I've had that.
Their offices are too crowded,
Yep.
or too small, or they have no chairs. You know, so be prepared that, you know,
For
you
a little
might
bit of
not
anything.
ever get inside the office, or that there's a beautiful conference room.
Yeah.
And then you'll be, wow.
It-
It depends.
I've had, you said, I've had meetings literally in the hallway, walking around with folks trying to find a conference room for us, and they can't. The other thing I've noticed, especially on the representative side, a lot of times you end up in the boss's office, as they call it, but that doesn't happen very often in the Senate. Just kind of anecdotal from what I've seen.
And the other part is, I think, you may not always talk to the Congress, you might talk to the staff.
Yeah, I would say probably 95% of the meetings will be with staff. You may get a surprise. The congressman may show up, but
Just to clarify.
yeah.
We're going to go to the Senate building and the House building. We're going to walk.
So
Walk on the ground?
we'll spend the morning in the House, and then the afternoon in the Senate. There is a subway car thing that they've made that goes between the Senate side and the House side. I don't know if we'll be allowed to use it. I haven't heard yet. The last time I was on the Hill, they were very strict and they weren't letting visitors on the Capitol subway thing. I don't know if that's still the case. I hope it's not. It makes it a lot easier. But if not, we'll have to go outside and walk around.
And then to clarify, I guess just so you guys, This is my first time attending an event like this.
Awesome, welcome.
I'm a medical student from VW, and I thought this would be valuable opportunity and experience for me. I'm curious, are there any other medical professionals that participate in the advocacy event that's going to happen tomorrow, or is it primarily patients and their family members?
So I don't know what the exact breakdown is for this year, but in the past, we're majority patients, but we do have physicians. Like Dr. Shaw usually comes on the Hill with us. He wasn't able to this year, he had a prior commitment, but we usually do have a handful of physicians or industry who are around that'll join us. I just don't know what the breakdown is for this year. Cecile will know, yeah. Yeah, when she comes down, she'll know.
Cecile was the woman.
Correct, yeah, she's the president and executive director for IFFGD. Okay, anything else? Thank you, everybody, for bearing with me going through all that. I know it was hard, but we want to try to open up a dialogue and get to know each other a little bit before tomorrow. That we can make sure we are efficient as possible. So thank you. Thank you.
Hi, I'm Julia. I'm a patient advocate with IFFGD. I have gastroparesis, but I also work in health policy advocacy and political strategy. I work with McDermott Plus Consulting, which is who will be helping us tomorrow during the meetings. We will be leading the teams around the Capitol, navigating the tunnels below the office buildings, and scheduling all of the meetings. So I wanted to give you a brief introduction to conducting a Hill visit. I know some of you might have done this before. Some of you, this might be your first time. And so I thought it'd be good to kind of get back to the basics, talk about what it will look like, and then I'll have a second session with you later this afternoon where we will practice what those meetings will look like with each other. So an agenda for today, we're going to discuss kind of the general flow of the Hill meetings, go over some tips and tricks and some things to keep in mind while you're doing them. We'll break down kind of an example meeting, and I'll give you some language that you can use during it, and then we'll ask some questions and get started on your pitch to lawmakers and issues you care about. So when you go to these meetings, there's kind of a flow that happens within them. First, you're going to have a quick introduction session. The staffer will introduce themselves to you, and your team lead, who will be one of my colleagues or me, will start the introductions. They'll say, hi, I'm with the International Foundation for Gastrointestinal Disease, and they'll pass it off to you all. And you'll give a brief introduction, and I'll give you some language for how to do that in a little bit. Then we will go do some background on what IFFGD is to them and background on the issue. These are staffers who deal with a lot of different policy priorities, and so they might not know as much about step therapy or copay accumulators as you do, particularly after these sessions today, but also your real life stories and you as a patient. And then we're going to ask them to do something. We're always going to ask them to do something. And so we want them to co-sponsor legislation or put in an appropriations request, and I'll kind of go over that. And then we will have time for discussions and questions. Briefly, I'd like to go over really quick before we get into tips and tricks, kind of how a bill becomes a law. I'll go over this very quickly, but essentially a bill is a policy that you would like to change in the US. You're going to introduce that, either a representative or senator can introduce that on the floor. Anyone can do it. Anyone can introduce a bill on any of the things that the federal government is able to legislate on. So for the bills we're talking about today, they've already been introduced on the floor. After they're introduced, oftentimes they'll be talked about in a committee. So on the House, it might be talked about in several committees. In the Senate, it'll be talked about in one committee. These committees have jurisdiction or purview over a few issues that are relevant. Some cover healthcare, which are the ones that we're interested in. They will work together to have hearings on different bills, and then they will mark up a bill, which means that they can throw amendments on it and then vote it out of committee. That's how it gets put on the floor for a vote for the whole chamber, which is the whole House of Representatives or the whole Senate. They will vote on it, bring it out to committee. Then if you're lucky enough to get that far with the bill, then it will be put on the floor and people will vote yay or nay. After that, it'll be sent over to the other side. So if it's started in the House, it'll be sent to the Senate. If it started in the Senate, it'll be sent to the House. That process will start all over again. It'll go in committee. They'll talk about it. They'll mark it up. They'll vote it out of committee. They'll vote about it on the floor. If that happens, miraculously, the bill goes and passes the House and passes the Senate, then it will be sent over to the president, and the president will sign it into law. That's like very Schoolhouse Rock overview of what happens with that. So with that background, there's also something called co-sponsoring, which John might have talked to you about. But co-sponsoring is when someone introduces a bill, they are the sponsor of that bill. But if you want to rally behind that bill and get committees to talk about it, get it through that markup phase, put it on the floor, then you can choose to co-sponsor that bill. And that's what we're asking a lot of these representatives to do, is to co-sponsor the bills that we really care about, which will show them, it will signal to other leaders that this is a bill that a lot of people want to talk about, a lot of people want to vote on, a lot of representatives or senators want to vote on, and it will be more likely to reach those next steps in the process. So I think that's an important part of all of this. So I'm going to go over some general tips and tricks first. So we will have team leads. You'll see on your papers with your schedules, there's a team lead at the top. It'll be one of my colleagues. They're very experienced in doing these types of meetings. They go with advocacy groups like yourself a lot over to the Hill to talk to different staffers. They will be the MC for the meeting. So they're not the ones conducting the meeting. They're not necessarily going to be sharing their own stories or own thoughts on any legislation, but they are going to help you facilitate the meeting. And that'll be with, there's a staffer there, they'll be there, and then all of the patient advocates will be there, and they'll be able to kind of help direct the flow of the meeting if we get off track. They'll make sure we don't forget to ask our ask, or they will prompt you to introduce yourself. So kind of rely on them to help facilitate how the meeting goes, and really that means you can focus on your own personal story and then how policy issues affect you. And that brings me to my next point. The goal of this meeting is to educate staff on what it's like to live in your situation, what it's like to live with the disease you have, or what it's like to be a healthcare professional. Any of that is what this meeting is about. And so what we also want to do is connect your lived experience with policies and legislation that they can impact. Whatever they pass in the House of Representatives or in the Senate, whatever becomes law, will materially impact your day-to-day life. Like step therapy. If they pass that legislation, it means you wouldn't, drugs wouldn't have to fail you over and over and over again before you get the drug you need. Or copay accumulators, that'll could save you thousands of dollars a year. And we want to make sure they see that connection from your story and the issues that you face every day and the policies that they can enact. And then remember your specific ask. Like, we want to really connect the policies that they can work with to your individual story. And of course, the team leads will help and make sure that those asks are asked. Another one, a lot of these members you might be a constituent of, but even if you're not, try to find a personal connection to either the member or the staffer. So if you're in that district, where do you live in that district? Do you go to high school in that district? I think it's useful to remember that. But then also, try to really connect with the person you're speaking to on a human level. It's going to make them more likely to remember you. Also, try to tie yourself into a bigger picture when you're talking to them. You're talking to them because this legislation or these policies might help you individually, but it will also help thousands and thousands of people in the US. And so it's important to say, hey, I'm only one person. For me, I'm only one person with gastroparesis. This will help me, but it'll also help a lot of other people with gastroparesis, with digestive diseases, and who are living with chronic illness. And then work with your team leads to identify follow-up opportunities. These people are public servants. They come in every day to serve the public, and so it is really important to maintain a relationship with them. You can email them afterwards. It's really nice to send a follow-up thank you email, and your team lead will help with that. But if anything happens, if a new bill you see gets introduced, or you want to remind them of your policy priorities, you can always email them afterwards and maintain a connection with them, and I think that's really valuable. So some things to keep in mind as we move into this, particularly if you haven't been on the Hill before. I think it's really important to remember that we'll be meeting with staff professionals. Their job is to help their boss, the congressperson or the senator, to make policy decisions. They have dedicated their career to policy. They have not dedicated their career to politics necessarily. And so what's really important is to remember that even if you have something positive, but also if you have something negative to say about campaigns or about the political ideology of their boss, right now is just not the time to say it. I totally get that it is an election year. Things are very polarized. We all have our personal convictions about what's going on. I'm with you on that. In this moment, we are there on a mission, and that mission is to enact policy that's really important. And the best way to do that is to build a connection and be kind and respectful to the staff member, because they're way more likely to do what you would like them to do if you build that personal connection and are kind to them. That also means that, or going off of that, I also want to say staff are gatekeepers and decision makers. They might not be the representative or senator, but a lot of times it's even better to meet with them because they are the ones who make the recommendations to their boss about what they should or should not support. They are the ones who are steeped in the health policy issues of today. They are the ones who understand the legislation that is out there, and they are the ones who choose whether to tell their boss to co-sponsor a piece of legislation, to vote yes or no. And so really treat them with respect and try to form that human connection and treat them with kindness so that they're more likely to do the important things that you would like them to do and advance our policy priorities. Going off of that, right now, everyone is coming to the Hill to talk about their policy priorities. It's the perfect time to. That's why it's really good you're here. They're starting to work on the budget for 2025, which means that everyone wants to, get their priorities in. They want their thing funded. They want to make sure that their legislation is passed. That means that they're just really overworked and busy right now. And so you might have to accommodate things you might not normally accommodate when meeting someone for a face-to-face meeting. It means that they also have just really small amount of spaces. They have small offices that don't hold a lot of people. So you might have to meet in the hallway because they don't have enough seats for everyone inside. It's really annoying, but it's also just the reality that they work in, and we still have to treat them with respect, and they are still taking time out of their day to talk to you, and that's still very valuable. And then also just a rule of thumb, do not take pictures or record during the meetings, particularly if you have not told them that. They did not consent to being recorded or having pictures taken of them. If you would like a picture, you need to ask, and generally the best time to do it would be at the end of the meeting. Yes, does anyone have any questions about some tips and tricks or things to keep in mind?
I have a question.
Yeah.
Say, for example, being mindful of the little time that they may have, to provide for you. Say, for example, there's somebody who wanted to be able to say something but didn't get the opportunity. They still can, email at a later
Absolutely.
time, to get their message across.
100%, yes. These are going to be, we're scheduled for 30-minute meetings. You probably can't convey your entire story in 30 minutes. And so if you would like to follow up with that senator or representative's office, with that staffer, you absolutely can. We'll be leaving them with handouts of IFFGD's legislative agenda, so they'll have information about what bills we support and what funding requests we have. But if you would like to share more about your story, or you guys didn't have enough time to get to something that you really wanted to talk about, I absolutely encourage you to email your staffer and let them know. And team leads will have access to all of their emails, or you can ask for a business card. Business cards are used a lot on the Hill nowadays, and so ask for their business card, and it'll have their email on it, and reach out to them. They want that. Yeah. So I want to kind of get into a little bit of language and what an example meeting might look like. And so I'm going to go through kind of that meeting flow of that I talked about earlier and give you some examples of what I might say if I was in your shoes and coming to the Hill. And then we're going to break out into our own individual groups, look through that legislative agenda, ask me any questions you have about the legislative agenda, and then kind of start planning about what specific things do you want to talk about. So I'm going to back up these slides here and go over to the meeting flow. Oh, there we go. So you're going to start with quick introductions. I mentioned that. One of my colleagues from McDermott Plus, your team lead, will probably kick it off. They'll say, hi, I'm with the International Foundation for Gastrointestinal Disease. I'm going to turn it over so that each of my patient advocates can introduce themselves, or each of my advocates can introduce themselves. When it's your time to introduce yourself, we're going to keep it really short and sweet. We're talking 2 to 3 minutes total for everyone to introduce themselves. And so that will be, for me, I would say, hi, I'm Julia. I'm from Virginia, which is where I'm originally from, or I'll say I'm from DC because this is where I live. So, hi, I'm Julia. I'm from DC. I have gastroparesis, which is a disease that means my stomach digests food more slowly and has a harder time absorbing nutrients. That's all I'm going to say in my introduction. So I'm going to hit some key points. I'm going to say my name, I'm going to say where I'm from, and particularly if I'm in an office of someone who represents me, and I'm going to say my disease and kind of explain what it is. If you're not here because you have a disease, then you'll say your connection to digestive disease. And so I think that you will give them a primer on why you're here, but you don't need to get into the nitty-gritty necessarily of what it means to you. After that, your team lead, after everyone has introduced themselves and the staffer has introduced themselves, we're going to move into background on IFFGD and the issue. So we're going to delegate over to, most of the groups will have a staff member from IFFGD in them or a board member. They can give a really brief overview of what IFFGD does and who they are, like 1 minute. And then we're going to move over to the issue. So when we're talking to our staffers, we have, if you can look in your briefing book, these awesome, 4 pages of our legislative agenda. We, to your point, Melody, we might not get a chance to talk about all of these issues. And so I think it's really important for each of us to work with our groups and to look inward about what is the most important thing that I want to convey to them. I have gastroparesis. There are not a lot of treatments out there for me. So something like step therapy, it's important to me because I care about people who need it, but it's not as important to me as something like research, because funding research is what's really going to make a difference in my life, because there just aren't even the drugs. But if you pay, thousands of dollars a month for your medication, you might really care about copay accumulators. Or if you have had to fail medication over and over and over again, you'll care about step therapy. So when we break in a minute, we're going to go through kind of you're going to read through the legislative agenda and ask me questions and figure out what 1 or 2 topics really mean the most to you. And then when we turn it over to the background on the issue and specific ask portion of the meeting, that's what you're going to talk about. And so for me, what I would do if I was a patient advocate, I would say, as I told you before, I have gastroparesis. I have a really hard time finding any sort of treatment options that are available to me because there's only one FDA-approved treatment, and it's not always great for long-term use, and a lot of people, it just doesn't work for them at all. That means that I really care about funding digestive disease research, and that's why today we're asking you to increase NIH funding research and NIDDK research, because these programs and this research would kind of, improve my quality of life if we could find another sort of treatment for my disease. That's kind of what that would look like. And to break that down, I would say, my story, what it means for me, what I really have a hard time with, what issue resonates the most with me because of my disease, and then I would go into our specific ask. Now, for other people who might care about something that's not research funding, which I think is a lot of you, there are other things like asking people to be a co-sponsor of a bill that would impact you. That's what your ask would be. And so if you look through this legislative brief, it'll say our ask. As you look through there, pick 1 or 2 things that really resonate with you, ask me some questions, and then also think about, is there something else that resonates with you a lot as a patient? So we're focused on digestive disease funding, or digestive disease policies today, and what that means in that sense. But is there something on here that really matters to you that you don't see? And we can talk about it and talk about, in these breakout sessions, talk about something else that might work for you. These are IFFGD's priorities, but it is really about you and showcasing your asks and your priorities. And then after everyone kind of goes around and gives some background on issues that are important to them, then we'll get into discussion and questions with the staffer. Those discussions and questions will often be staffer-led. They will say, oh, can you tell me more about what gastroparesis means in your life? Or can you tell me more about the numbers of funding that you're asking for? And that's where this will come in. They'll be getting a copy of this, but also they might ask about specifics of legislation, and that's where your team lead will come in. That's where they can say, oh, it has this many co-sponsors, or oh, the bill number is this. That's also very helpful. So you have, this discussion and question section is really going to be led by the staff member and kind of figure out where the meeting is headed. If they don't have a ton of questions, you might be able to talk about another priority. If they do have a lot of questions, you might not get to everything you talked about. So it's really just remember at the end of the day, it's just a conversation with another human who cares about the stuff and wants to understand the impacts of what they do on the Hill in these offices, what it really means for the day-to-day lives of people. So that's the end of my spiel for today. I would love to hear for this session, I have another one later, but if you'll hear from me again, but if you have any questions about anything I just said, I would love to hear them. No question too small. If not, then we'll kind of break out into independent work and we can look through the legislative brief, and I'll be here to answer your questions there too. Also logistical questions. I know you have your schedules. If you've never been before, let me know. So yeah, any questions from anyone?
Regarding NIH funding, do they pass a total NIH funding bill, or is it broken down by institute?
So they pass an HHS funding bill. So they will just fund the Health and Human Services Department overall. And then they might break it down into individual departments, depending on how the appropriations bill is written. And then this is getting a little technical, but basically committees will then write a report and they'll say, this is how exactly we want you to spend that money. So it's not necessarily in law, but they'll include it in an appropriations report, and that's broken down, that can be broken down into different institutes.
The reason I ask is there's one institute, NIDDK, which is of specific relevance to this group of digestive disease, and that's where you want to see the increased funding go, not to another institute.
Absolutely.
Just being selfish about it.
Oh, absolutely. So what we're saying here in our ask is that we would like $51.3 billion to go to the NIH in total. That would be an increase of about $4 billion from the previous spending bill. So we would like all of that to go to that. We would like a proportional increase for NIDDK. So that means like if we increased $4 billion for the NIH, then we would like proportionally that much to go up for the NIDDK from their last budget.
So it's kind of, I was thinking it was the same, but it also probably would depend on what was the prior budget for the other one.
The NIDDK, yep. So we're asking for less than a 10% increase for the NIH, so we would ask for a little less than a 10% increase for the NIDDK. Yes?
Not to get into the nitty-gritty of this, but how much, is that like on par with how much it increases every year or every congressional cycle?
So that's a great question. For reference, you always want to ask for a little more than you think that you're going to get, right? So the administration, currently the Biden administration releases a budget every year that asks Congress and says, this is how much we think that we need this year to do everything we want to do. Just to give them kind of an idea of what they do. It's called the president's budget. It doesn't have any actual material impact necessarily, but it kind of gives them a gauge for how much the administration really wants. The administration has asked for $51.1 billion for the NIH for fiscal year 2025. So it's on par with what the administration thinks is necessary and what they would like to do. We're expecting to get a little less than that, but it will be an increase from the $47.7 billion, especially if we continue to advocate. So we want them to know that there are people who really care that this funding goes up, and that's not just us. There are other patient groups, organizations, advocacy organizations who are asking for that exact same increase, which presents a united front and shows that we all really care about this going up. Okay, well, why don't we kind of take a break for a second, look through that brief and everything, and I'll be here if you have any questions, also logistical questions. One last thing I'd like to add is that we will also have, lots of things going on tomorrow. I know that sometimes for me, my stomach flares up and I can't help when, particularly after breakfast or lunch. If you need a break of any kind, let your team lead know. We'll get you back to my office, which is right next to the Senate buildings, the McDermott building, and there are rooms set up with water, air conditioning, a nice place to sit that's quiet. And so if you need to, skip a meeting and then come back, whatnot, I have a colleague there who will be manning that room all day and will help you get where you need to go. But you have an opportunity for a break during the day. We also built in breaks to your schedule, so we're hoping that it's not too overwhelming, but you can't decide when a flare-up happens. And so if you need a break, we'll have a place for you to do that.
Wear comfortable shoes.
Correct. Yes.
Most important.
Yes.
Maybe doing
A lot of walking.
Yeah, a lot of walking. We'll be doing House buildings in the morning, so we'll be meeting with representatives' office in the morning, and then senators in the afternoon. So we won't have to walk back and forth between the House and Senate, but we will have to walk that once, and then go between the House buildings and between the Senate buildings. The good news is that the tunnels underground are open now, and so to get from House to House building or Senate to Senate building, we don't have to go outside. We go through security once and then go in between. But we are gonna have to walk outside, and it will be a little hot, walk or Uber outside to get to the Senate buildings. All right. Well, let me know if you have any other questions. I'm here, and then I will be back later where we'll actually practice our meetings because it's really good to just do it at least once before you go.
I'm Melissa Sutton. I am the program coordinator at IFFGD. I've been working with them now since 2020. I do have one GI disorder. It's not something that bothers me every day, but it's something that I can relate to when it does flare up. So today I'm going to talk to you guys a little bit about insurance and how to choose your insurance. I'm sure everyone in this room hopefully has health insurance. So you guys probably already know some of these terms. Just in case you don't, I'm just going to run through them super quickly. Your premium for your insurance is that monthly payment that you guys pay out of pocket from your paycheck, just so that you have coverage. Your deductible is going to be what you pay out of pocket. Some plans have 2 deductibles, one for in-network coverage, one for out-of-network coverage. Other plans can have 2 deductibles, one for health services and one for drug coverage. So it's important to know if your plan has one, has multiple, and what it actually covers. The co-insurance, some plans have this. This is where you share a percentage of your cost with your insurance company. Sometimes it's the 90-10 plan, sometimes it's called 80-20, sometimes 70-30, it depends on what you choose. But let's say you chose the 90-10 plan. After you meet your deductible, sometimes before, you pay 10% of the bill while your insurance company will pay 90%. The copay is a fixed amount that you're required to pay for just doctor's visits. Some plans have copays, some plans don't. Usually your primary care doctor is your lowest copay, and that copay goes up for specialists and urgent cares, and then the highest one is typically for emergency room visits. And then your out-of-pocket maximum is typically what you have to pay out of pocket for the entire year. It includes your copay and your coinsurance and your deductibles, but your premiums don't go towards your out-of-pocket maximum. So just some questions to ask if you're thinking about changing an insurance plan, or maybe you have a child that is getting off of your insurance plan. One is, will this health insurance plan be affordable if I get sick? If you get some kind of chronic illness and you do have to visit the ER a lot, is this something that you can afford? Are my providers covered by this plan? So you might already have ones that you're super comfortable with, you don't want to switch. Some insurance plans have a smaller provider network, which means that you can't see possibly the same provider that you currently see. So it's important to make sure that they're considered in-network for the plan that you choose. What is this health insurance plan's drug coverage like? If you already take prescription medications and you're paying a reasonable price, if you're about to switch, is it going to be a reasonable amount of money that you're going to pay, or are those costs going to go up for you? Will this plan make it easier to get care if I get sick? That kind of ties into, is your healthcare provider listed in your network? Sometimes if it's not listed in your network, let's say you have a GI disorder like all of us in the room, and you need to see a gastroenterologist often, is it easy to get into that provider, or do you always need to get a referral every time you see a specialist? Does this plan cover any type of alternative therapies, such as a chiropractor, an acupuncturist, a nutritionist, or behavioral health? Sometimes insurance plans do not cover that. Sometimes they'll say, I'll cover 7 visits to a chiropractor, but then you're on your own. So it's important to know those things before choosing. And then finally, will this insurance plan be right for me if my situation changes? What if you have kids? Is it affordable if you start having kids? If you are getting a new job that requires you to travel, is it something that's going to cover you out of state or even nationwide, or even in other countries if you have to have emergency services? So that's important to consider as well. Okay, so this is 5 different types of insurance. I want to clarify that your high deductible health plan, that one all the way at the end, that can be considered a PPO or an HMO or a POS or an EPO. It can fall under any of those categories, but sometimes it is on its own. So we're going to talk about the difference between these 5 types of commercial insurance. First, with the PPO, you're going to have a high premium, a high deductible. So remember that premium is going to be what you pay monthly. If you can't afford something that's a lot of money monthly, it's not a good choice. Your HMO has low premiums, low deductibles. That's always great. Your POS insurance, which is point of service, has low premiums and high deductibles. Your EPO has low premiums, low deductibles, and your HDHP plan, your high deductible plan, has low premiums but a very high deductible. Your PPO insurance is going to give you state or nationwide coverage and out-of-network coverage. Your HMO plan isn't going to give you any out-of-network coverage. So even though you have that low premium, low deductible, you have a limited amount of choice of who you see. Your POS insurance, once you meet your deductible, you then can get covered for out-of-network services. And then EPO only covers you for emergency situations if it's out of coverage. And the high deductible plan has 2 different deductibles, like I talked about earlier, one for providers that are in network and one for providers that are out of network. So then talking about copay coinsurance, your PPO has low copay, low coinsurance. Your HMO has a very low copay. I do not believe that there's coinsurance involved in the HMO plan. POS has a high copay, same with your EPO, and then your high deductible plan has a low coinsurance, also a low copay. And I know that because I have the high deductible plan. And then so finally, thinking about all those things, you're gonna pay higher out-of-pocket costs, but the benefit is you have a larger provider network that you get to choose from. You have that flexibility to travel. You have the flexibility to go to lots of different providers, so it still could be a good choice for you, especially if you're somebody that already pays astronomical costs for your healthcare service. Your HMO plan is going to be lower out-of-pocket costs, but it's less flexible because now you have a very small provider network, and typically if you want to see a specialist like a GI doctor or like an ENT, you have to make sure you get a referral from your primary care doctor. And again, these are just kind of like the standard. All of these plans are going to vary depending on the type of insurance company that you get. You know, you can get a PPO plan with something like Blue Cross. You can also get it with Aetna. So these plans are going to vary, but this is kind of standard what you most likely will see, but it doesn't always guarantee this is going to be your situation. So that POS insurance, lower out-of-pocket costs than something like a PPO. It's going to be higher than your HMO. You're going to have a small provider network, and according to the things that I've read about it, never had this insurance, but it typically requires a lot of paperwork and can be confusing for a lot of patients. Your EPO has a lower out-of-pocket cost and a larger provider network, so you just have to think about if that's right for you. If you're somebody that never travels, or you really only ever have emergency situations, that may be a good plan to consider. and that high deductible plan, you do have a larger network and it is higher out-of-pocket costs. So again, think about what you're paying and the services that also it's going to provide to you as the patient. Just kind of talking about Medicare and Medicaid, I know a lot of the patients that have any type of chronic illness fall under these two categories. Your Medicare insurance is federal health insurance. You usually have to be 65 or older to qualify. However, some conditions will also allow you to qualify, depending on what they are. And also, I was reading that it's possible you have to be on disability or some type of Social Security benefit for at least 2 years if you're under the age of 65 in order to qualify if you don't have a specific condition that already qualifies you. And Medicaid, it's a joint federal combined program, which makes it so that some services are mandatory because they've been set by the federal government. Some are optional because those have been set by the state. So those plans can vary state to state. And the one negative is that you don't qualify for any patient assistance programs if you are a part of Medicare or Medicaid, which I'll talk about those programs in a minute. I know that was a lot of information to kind of take in. Does anyone have any questions about that? Yes.
Yeah, I have a question. You mentioned for the EPO, it's out-of-network coverage for emergencies only. Is that for like in-state, the plan that you have, or it's like travel?
That's a really great question. So she asked, if you didn't hear, if the EPO insurance plan would cover you for out-of-state or if that only works for in-state with emergency coverage only. I am honestly not sure. That's a great question, and I can go back and do some searching, and I'll let you know. Absolutely, great question. So how might the insurance policy that you choose affect you? If you're somebody with a chronic disorder, you see a specialist monthly, you always have to go to the ER to get your services, or you need something like surgeries, a higher deductible plan might make more sense because you get more coverage, you can see more specialists. If you're an individual that's about to start a family, I know because I'm about to add an addition to mine, it's very expensive to add a child to your insurance plan. So you have to make sure that that's an affordable choice for you with the one that you have. If you're somebody that rarely goes into the doctor, you just have annual checkups, or you have an existing condition that's well managed and well controlled, something like a low premium, low deductible plan might be best for you. And or if you frequently travel a lot due to personal reasons, or you have a child that goes to college out of state, and you wanna make sure that you guys are having every coverage that you can, something like that PPO or the high deductible health plan may be good for you. Okay, so now talking about drug coverage. So this is a big one, right? So some questions to think about before choosing your plan when it comes to medications is, how much are you gonna pay for those regular prescriptions? Which pharmacies near you are considered in-network versus out-of-network? What are the options that you have if your prescriptions end up not being covered? And how do you access your drug formulary? Which we'll talk about that in the next slide. So every plan will have a drug formulary. Sometimes it's hidden, sometimes it's easy to find. But what this is gonna do is it's gonna tell you what type of drugs are covered by your health plan, and it's going to typically divide them into tiers of being a generic brand name, your kind of more expensive drugs, and your biologic, your biosimilars that are kind of for more rare conditions. And some of them will even list what tests or medical procedures are going to be covered. It just depends on your insurance company and also their pharmacy benefit manager, that PBM. So these are the different tiers that your drug can fall into. Tier 1 is those least expensive generic brands. Remember, generic is typically the same as a brand name drug. It's just some of the inactive ingredients, I believe, that are just different, and just the price that you pay is going to be different. Those tier 2 drugs are going to be your brand name drugs that your plan has designated as preferred. And this is where you're going to find more affordable brand name options. Your non-preferred or expensive brand drugs are typically going to be in your tier 3. These drugs are going to cost you a significant amount more out of pocket. And then notice that the triangle here gets smaller. That's because less drugs are going to fall under tier 4, but that's because it's for your rare conditions, less people need them, but these are the most expensive that you're going to pay. Those drugs are the most expensive. So I actually, I hope do we have internet in this room? Okay, awesome. So I was able to find my drug formulary. And I do want to specify that I have that high deductible plan. I have a commercial insurance through my husband's employer. And my insurance plan has nothing to do with my drug coverage. So I had to go to my PBM in order to access my drug formulary. But then it was really easy to find, and I had never seen it before, so I just wanted to show you guys a little bit about what it looks like. So they divide.
You're gonna take it off display mode.
Oh.
The presentation.
I'll fix it real quick.
Oh, thanks, John. But it's divided up. Yes.
What is a PBM again?
Pharmacy benefit manager. I don't know if it's the same thing as pharmacy vendor. We were a little confused about that. But our drug formulary, or my drug formulary, I should say, is typically divided up by the type of drug that it is, so it's pretty easy to search through. So it does have a lot that you can see. It doesn't divide the medications up by tiers, which I did find a little inconvenient. They did have a separate document where you can find what some of the tiers for these medications are, but you can also call your pharmacy and ask them specifically what tier your medication would fall under. The next thing that I thought was very interesting that I didn't know before was that you can also find out which of the medications that you take are going to need a prior authorization. I know that Dr. Shaw talked about that a little bit. I'm going to go down. I didn't mean to put my insurance there, but I don't know where it is. Oh, here we go. So it's just going to list the type of medications that are going to need a prior authorization or that may need a prior authorization so that you can go in and you can let your doctor know that beforehand if it's something that they don't know. Yes?
You're saying that this is not related to your insurance plan? This is something, a different entity?
So insurance plans and employers specifically can negotiate with the pharmacy vendor to have that taken away from the insurance plans. They only cover your health services sometimes, while the pharmacy is gonna they're gonna decide which of these medications is their preferred and which ones they believe are best for patients.
And they do that with all like pharmacy vendors or like with some
It depends on the company of the insurance. Some do the negotiations with them, some do handle the drug coverage in your insurance plan. It's just that mine specifically, through the one that my husband has, does not. They do it separate.
Generally, if you look at your insurance card, on the front of the card, it might say, like for me, it says United, and it has all my numbers, and if I flip it over, it has prescription coverage, and then there's another name.
Yes.
Right? Now, if you flip it over and it says prescription coverage and there's a phone number, it's probably handled by the same insurance company. But what they do is they farm it out. They say, United says we want to specialize in health services, doctor visits, hospital visits. That's what we want to do. We don't want to worry about what the FDA is approving, what all's on the recall list, how much are we going to, what are we going to do with copay accumulators, right? They don't want to focus on that, so they farm that out to a third party, which is your PBM. And then the PBM does all of that and then tells them, this is what we're doing.
Correct. Yeah. Which I wouldn't have known until I did this presentation as well. I assumed it was all under the same thing. So what else I thought was cool was I was able to access my pharmacy vendor. I was able to make an account online. And I was able to compare all the pharmacies in my area for a drug that I actually do take for my anxiety. Now, that being said, I typically go to pharmacy number 1. And so I've been paying $12.33 a month. Before I found this tool, which I didn't find it until a couple weeks ago, I realized that if I went to a different pharmacy that's not a name brand pharmacy, that's just a hometown one, I would pay $10 less, almost $10 full less. And it's not even that much farther. You go down, there's another pharmacy that I could visit. I still get a discount, so I'd only pay $8.70. And this one was the farthest one away from me, but again, it's a cheaper price. You can do this. If you're not able to access your pharmacy vendor, or it doesn't let you do this online, I don't know that you can do it with Medicare or Medicaid, but what you can do is you can call the pharmacies yourself, and you can ask them how much that drug will cost. And so even though it's not conveniently there for you to just look at and compare, you can do that extra work to find out if you'll pay for a cheaper price somewhere else. So what if you are denied coverage for your medication? Stop and think. If you get a prescription filled or they ask you to go to a location to get services performed, you are not obligated to pay at that time. If it's way more than you expected it to be, call your healthcare provider, explain the situation that you're going through, and number one, ask them if there's a less expensive option of the drug that you can try, or ask them if you can have a procedure done at a different location. Because sometimes, again, if it's out of network, it's gonna cost you more out of pocket. So it's important for them to know if you're having trouble affording any type of drug coverage or any type of health services. Oops. Also, keep calm. Might just be a very simple issue going on. Everybody makes human mistakes. I make them all the time. Sometimes it's just a lack of insurance information. So you or your provider could have filled something out incorrectly. Sometimes things are missing versus sometimes it's filled out incorrectly. Sometimes they spell their names wrong. They could get your birthday wrong. Sometimes they can accidentally, I know I've done this before, I've accidentally given them my daughter's birthday instead of my own. And so those things happen. Sometimes they can even code things incorrectly. That happened to me once where they told me I owed money for some eye thing that I never had done, and it was just because it was just the wrong code put in. So I ended up working with my insurance company and they fixed it. Next, you want to know if that drug is listed on your drug formulary. If it is not, you can ask for something called a formulary exemption. Now, what this is going to do is basically say, this medication is necessary for you, you need it, so even though it's not listed on your drug formulary, you still need access to it. Your plan might also only cover the generic brand, and your provider may have given you the brand name medication. Remember, the generic usually costs less. It's usually still as effective, so if that's an option for you, you can typically get the generic instead. See if it's covered under a different location in your medical plan, because if it's in a different medical portion of your plan benefits, it can be helpful in terms of something like a compounded medication, where compounded medications kind of confuse me a little bit. But it's just a different, it's almost like a smaller amount with more in it. Does that make sense? We'll just hold off on the actual definition of a compounded medication for now. But otherwise, the FDA approval may have just recently happened. So it's possible that even though it's listed, or even though it's not on your drug formulary, that it is still FDA approved, but your insurance doesn't recognize it as being a viable option for you because it's so new and not enough doctors know about it. Let's say it is on your drug formulary. Sometimes, and Dr. Shaw mentioned this, you need a prior authorization before you can get access to it. Sometimes there's something called a quantity restriction, where if you are prescribed a 15 milligram pill twice a day, your insurance company can say, I can't give you those 60 pills, but what I can do is I can give you 30 milligrams and you can cut them up in half yourself. And that way I'll give you 30 total pills. Yes. Sometimes it's step therapy, which is what I know Dr. Shaw also talked about heavily this morning, where it requires you to say that you've tried a medication, but it has failed you. And so, or that they want you to take another more preferred medication before your plan is able to cover that prescription medication. Sometimes they don't deem that medication as being medically necessary or appropriate for your condition. And sometimes it's still viewed as an experimental or an investigational drug. And so they won't cover it still. So some other options that you have, if you're previously on a medication and you want to change insurance plans, you can ask for a one-time refill to allow you time to work with your healthcare provider on what other options you have. You can talk with your healthcare provider about any other medications that may work for you, or you can appeal the decision. So this is the appeals process for if you're still getting denied your drug. The first level of appeal is that you and your healthcare provider can talk to the insurance company. They're going to request that they reconsider the denial. Your doctor can also speak with a medical reviewer of this plan and have something called a peer-to-peer insurance review in order to challenge that decision. And the purpose of this is just to prove that the service meets the insurance guidelines and it was incorrectly rejected. It should not have been denied. The second level appeal is where it's reviewed by a medical director that is with the insurance company, who was not involved in the original claim decision that denied you. And the goal of this appeal is to prove that the request should be accepted within still the coverage guidelines. The third is an independent external review, and this is where an independent reviewer with the insurance company and a doctor with the same specialty as the doctor as you can take a look and determine if they should approve or deny the coverage. And you can ask for the external review in an internal appeal if it's not possible. You can ask for an external review if an internal appeal was not possible or if any of these are unsuccessful, but you'll have to try these first.
What is the timeline that this usually happens over?
Great question. So I do believe that you can have a rush process on the first level of appeal. So your healthcare provider can say, I need this reviewed within 72 hours. A lot of times, though, it takes months. Especially if you've been denied and have to go to that second level and then go to that third level, it can take a lot of time, which is very inconvenient for patients. So there are also other options that can help you save on the medication. The first is a cash pay option. Here's the trick, though. You have to ask for this. What this means is you can look at your pharmacy, the pharmacist, and you can say, if I don't go through my insurance for this medication, is it cheaper? And sometimes it is. And so, but they're not allowed to tell you that unless you ask. So you have to ask that question. Would this be cheaper if I paid myself and not go through the insurance?
I want to say, sometimes they will let you and sometimes they won't.
Pay out? Well, see, but you can ask them if it saves you money. And I believe that they should let you. So I would challenge that, honestly. Next, a lot of different organizations have something called a prescription discount card. I have linked one called Needy Meds. It's free. A lot of these can save you up to 80% on medications. Did it pop up? Yes. So this is something where you can print it out online. You can contact Needy Meds. They can mail you one for yourself. And the nice thing about this is you can use it for yourself and your kids and your aunt and your cousins. Anyone can use this card, and it can be used as many times as you need. And the last is, and I talked about this very briefly in the beginning, a patient assistance program, and I'm going to talk about what that is. So patient assistance programs, also known as PAPs, help those that either have no health care or that have limited health care. And they're typically managed by pharma companies. Sometimes they can be managed by nonprofits, and sometimes government agencies. Because remember, I did say that if you're Medicare, Medicaid, you most likely won't qualify for one that a pharmaceutical company has, but you may fall under one that a government agency can offer. Anyone that's struggling can apply unless, again, you have Medicaid or Medicare. Qualifying is going to vary depending on the insurance company. It's also going to vary depending on how much money you make. So some may qualify for more assistance, some may not qualify at all. Again, it kind of just depends on your situation. Where do you live? What insurance or lack of insurance do you have? And also, what's your income? A lot of these typically help people that are about 200% below the poverty level. And In terms of reapplying, sometimes you need to apply every year, sometimes you don't. Again, that's going to vary depending on the type of plan that's being offered and the type of insurance company pharma company that's offering it. Brand name medications are typically the ones you're going to qualify for here because the pharmaceutical companies are going to offer these programs for the drugs that they have and that they have designed and made. So sometimes, though, it can also cover your testing supplies, your testing strips, or any type of motility devices. Depending on your circumstances, you can have full coverage or partial coverage. And again, I just wanted to make it very clear that if you had Medicaid or Medicare, you're not going to qualify. Some, if you don't qualify for a patient assistance programs, still have savings programs. They're a little different. So sometimes you can ask them for a one-time 30-day medication. And sometimes, like I said, they're going to offer you a discount or a savings card that's still going to be able to be used at your local pharmacy and still be able to save you money. And finally, there are copay assistance programs, hopefully not copay accumulators along with that, so hopefully you're not going to pay more. But a lot of times they will allow you to pay less out of pocket if you are commercially insured, and it helps you afford those prescription medications that are very expensive. So this is just kind of our information on how to contact our organization. We have a spreadsheet of information on other nonprofits and other organizations that not only can help with prescription coverage, but that can also help with things like traveling to your doctor's appointment, that can help with things like more financial assistance in terms of specific surgeries. Sometimes it offers you gas cards, so it may not offer you the travel, but it might reimburse you on your gas prices. So if you're somebody that needs help with any of these things, even lodging purposes, you can always reach out to us and we can let you know if we have information on an organization that offers that, and we can help you get connected with them.
Hello, thank you for spending the last couple of hours with us here at the International Foundation for Gastrointestinal Disorders, or IFFGD. Again, my name is Cecile Rooker. I'm the President and Executive Director. For the last few hours, we've been giving you a lot of information about advocating for yourself, not just in Washington, but through the insurance process as well. I know it's been a lot. There's been a lot of information that's been given to you. Perhaps questions have come up throughout this program and you'd like to email us. Please do so. Our email address is iffgd@iffgd.org. We'd love to hear from you. Questions, comments, suggestions, feedback, something you felt like we missed, something you want to see in next year's advocacy agenda, please let us know by emailing us. Again, our email address is iffgd@iffgd.org. And before we leave for this evening, I definitely want to make sure that we acknowledge the supporters of our program. They have made it possible for us to provide this content for you, and we are grateful for their support.